from there. We have 140 people signed up for today's gathering of the Right Care Initiative community from across California, including leadership from each of our 4 communities that we have developed over the last 12 years, and some very special presenters that our chairman, Dr. Bill Baumer, will be introducing shortly. So as we now have 50 of the 140 people with us, I want to just start by thanking our supporters who, without whom we could not be gathering. So we are supported by the California Department of Public Health, the Los Angeles Department of Public Health, Blue Shield of California, and thank you, Dr. Scott Flynn from Blue Shield, for not only being one of our early chairmen of the University of Best Practices, but also for inspiring us to learn how to move to the virtual environment well before we had to pivot to do so in the pandemic environment. So thank you so much to all of our nurturers and our mothers this Mother's Day Monday as we join together to share best practices to prevent such dire outcomes as what befell my mother when I was 15, and she died of a stroke related to hypertension that was uncontrolled. So we have speakers today that are quite expert in controlling hypertension and other factors that lead to such dire outcomes, such as smoking cessation, lipid control, blood pressure control, blood sugar control. On this Mother's Day Monday, we welcome Dr. Earl So from the Veterans Administration of Los Angeles, Doctors Marilyn Stebbins and Rose Pavlakos from UCSF Telepharmacy, and Doctors Susan Ivy and Nisha Parikh from UC Berkeley and UCSF. And we wish to thank you for your leadership and your willingness to teach and share best practices in this public health emergency to prevent unnecessary, preventable disability and death. So we have with us from around the country new participants. So if you could go to the next slide, I would like to just review a little bit about the Right Care Initiative. So we work by improving critical metrics for control of blood pressure, blood sugar, and lipids in particular. And we have on our website in great detail who our partners are. I want to once again thank our supporters from Blue Shield, Amarin, Amgen, Boehringer Ingelheim, Genentech, Johnson & Johnson, Novo Nordisk, California Department of Public Health, Santa Clara Health Trust, LA County, and the University of Southern California, as well as all of the University of California campuses. We are a primarily volunteer-based project, a collaborative that's been building for 12 years now. We have 72 of the 140 people so far signed on. And I will just say that, welcome to those from Florida, Nevada, New Mexico, the Washington, D.C. area, and of course, all across our 4 University of Best Practices that we've built starting in 2011, San Diego, Sacramento, Los Angeles, and Santa Clara County Bay Area. So with that, I would like to just inspire you to listen to our fabulous speakers who have volunteered to share their best practices with you today. If you could go to the next slide, please. Dr. William Baumer is a super cardiologist from UC Davis who is our chairman of our Capital Region University Best Practices. I should say that this is our 7th virtual meeting of the University Best Practices since we went to social distancing at the end of February. So with that, Dr. Baumer, I'd like to just thank you once again for donating your time to inspire us all with speaking first about the nexus between the COVID-19 pandemic and cardiovascular, which is, of course, devastating to the heart. So thank you, Dr. Baumer, and welcome everyone to this 7th virtual Right Care University of Best Practices.
Well, thank you, Hattie, for the introduction. And I would like to get started because I would first like to welcome everyone on the post-Mother's Day. We are going to spend time on the COVID virus, as well as some issues that are important, telemedicine and women's health, which I think are critically important these days as well. If we could have the first slide up, Brian, if you could put it on the full screen for that. I don't have full screen on that. There we go. So we're going to go back to the first slide, please. So the topic that I wanted to address is COVID-19, which is the most lethal pandemic we have had in 102 years. So this is important, that this is something that probably no one else on the conference today has ever seen in their lifetime. Next slide. And the importance of it is shown here, is that COVID-19 has deaths. At our last meeting, we had less than 10,000 deaths. We're now up today over 80,000 deaths in the COVID-19 SARS-CoV mortality rate. So it's quickly gotten to be more deadly than influenza, which in the last year was only 34,000. So it's double that, increasing several thousand a day, and well may go into the 100 to 200,000 range here. Now, as important as it is, we have to realize that on the far left of the screen, heart attack and heart disease and stroke still outnumber the number of deaths. So we need to focus on COVID-19, but we can't forget that heart disease and stroke are still the #1 killers in the US for our population. So that's critically important. Of interest, though, is that COVID-19 and heart disease and stroke are not totally independent, because COVID-19, as we'll show, attacks individuals with pre-existing cardiovascular disease, and thereby some of the mortality of the COVID-19 is actually individuals who have underlying heart disease and stroke would not have died of their heart disease and stroke this year until they added COVID-19 to that. So it's not only independent, they are jointly responsible for an increasing number of deaths in the US and, of course, around the world. Next slide. So this is, in fact, the virus that we can see. It is an RNA virus. The pink area in the center, or the pink lines, are the mRNA ribosome that we see, surrounded by an envelope, which is then surrounded by spikes, which have been called corona because of the crown-like appearance that they have. At the bottom of the slide is the actual RNA sequence that is in the RNA of the virus. And that RNA sequence codes for a number of things, including the RNA, the nucleotides that are responsible for generating the envelope, the spikes, and some of the other enzymes that are associated with this particular virus. That RNA is a relatively long RNA or message for it. it is subject to mutations, and we have identified already at least 156 mutations in that virus. Why are those mutations important? Next slide. This slide shows that if we track those mutations in the genome, we can get information about where this virus has come from, what its characteristics are, and what it might do to humans after infection. So on the top happens to be the genome of the virus as it was first encountered in the Washington state of Washington virus outbreaks. And what you see is a couple of distinct lines that are shown there, a black line that seems to go through all of the rows on the top, and a red line that goes through those as well. And what we see is that there is a pattern there of the Washington viruses having the same mutation, suggesting that they may have come from the same case originally. The next set of rows are three orange rows that are underneath that. That happens to represent the virus that we encountered, the first community-acquired case in the US and saw at UC Davis. Notice that virus is totally different in the mutations of the nucleotides than the Washington viruses there. So we know our virus did not come from either the Prince's cruise lines or the individuals who initially had the disease in the state of Washington. It's a different origin for that. The next set, which are purple and green, happen to be the type of viruses that were encountered in Santa Clara County. And Santa Clara County has a different viral genome pattern, suggesting that the Santa Clara cases did not come from the Princess Cruise, did not come from the state of Washington, did not come from Solano County or UC Davis or Sacramento. They were separately, a different host was the one that infected that. And at the bottom, we see actually another group of viruses from Europe and from New York City, and those differ as well. So we know that there are different hosts for each of these. There are multiple viruses. This virus has an error in it or a mutation, approximately 1 in every 10,000 replications for that virus. And therefore, we know that there are a number of mutations that are out there, leading to some of the species of this virus being more able to infect. And we do know that the New York City brand of virus tends to be more infectious from the mutations it acquired. And when a more infectious variety of this virus enters a population, it tends to take over and dominate and, in fact, outperform the other viral varieties that are there. So it's interesting. It allows us to track where this came from. It allows us to predict what will happen with this virus as it affects humans. And it's certainly interesting that we can come up with these genome sequences within hours or days of a new virus as it appears. Next slide. So this is actually a schematic of the diagram of the virus in the center. The blue spikes are the typical spike protein that exists on this. That spike protein does require attachment to a specific converting enzyme on the surface of our cells, mammalian host cells, called ACE2. It makes an attachment, but only after it has been activated by a separate TMPRSS2 receptor on our cells. The reason I show this is that the virus has to actually attach to the edge of our cells, and that attachment is a space that is less than a micron in distance, meaning that virus does not fly, does not swim, does not get around by itself. It is required to be put within less than a micron of our cell surface to get in a susceptible cell at that time. which outlines for us one of the key ways of preventing viral uh, obtaining this virus is to stay more than 1 micron away from this virus. And that's why the recommendations are to stay 6 feet away from any individual, wear masks and protective equipment to prevent this virus from getting close contact to a host cell in our body, mostly the respiratory or nasal pharynx, where it attaches to the cells and enters the body. And thereafter, the virus turns our cells on to manufacturing copies of itself. Next slide. So this just shows, we said that the virus has to get extremely close to our cells to have any chance of entering the cells. This slide shows that the virus is kind of fragile as well. And what we know is the envelope of the virus that we can see there is a lipid membrane that is very fragile and is in fact destroyed by soap or surfactants, alcohol, and disinfectants. It's quickly, in fact, disinfected or destroyed by those agents. It's also destroyed by increasing heat, drying out on a surface. It's also subject to destruction by UV or sunlight, etc. So this is a very fragile virus, and that this is now the second part of our protection scheme. One was to be separate by more than 6 feet, wear masks and protective equipment. The next is to sanitize, disinfect, or just use soap on your hands washing or on the surfaces that you're in contact with. Because if the virus is on a surface and your finger or hand touches it and then goes to your eye, your mouth, or your nose, that can be a way of getting close to those cells. So we do want to make sure that we use environmental protection on surfaces that we are likely to come into contact with. Next slide. Once you, in fact, encounter this virus, what would be the symptoms and what would you worry about? Well, on the left, we see the symptoms of the virus, which are manifold, and therefore lots of things: sore throat, dry cough, headache, in fact, toe pain, diarrhea, nausea. All of those can be part of it. So if you're feeling sick and have any of these symptoms and you're at high risk for this disease, you may want to contact your healthcare provider right away, especially if you have a fever. That is a high chance that you might have the SARS-CoV-2 virus and have the COVID-19 disease. On the right, it shows what the systems that this virus infects, and it's literally head to toe on the body, as you can see, and every major organ system in the body can be involved with this. So this can have a multitude of presentations throughout the body. And because it affects many of our vital organs, it can have serious and deadly consequences. Next slide. The first area that it usually involves is often the lungs, shown a diagram of the lungs. Early involvement on the lungs on the left shows that we activate the alveolar, we affect the alveolar cell. We then activate macrophages and T cells to try to fight it. After the disease progresses, though, there may be more inflammatory cells that are recruited into the area, and there can be a leak or a capillary leak where we get a hyaline membrane shown as the pink area on the bottom of the alveolus. And that area, in fact, is often seen as a ground glass appearance on chest x-ray and is sometimes recognizable right away as this type of viral pneumonia. This viral pneumonia can lead to significant hypoxia, and many of the deaths associated with COVID-19 can be respiratory deaths that develop. They develop not only because of the damage from the virus and the proteins, toxic proteins released, but also by the over-aggressive inflammatory response that leads to additional damage within the cell lining. And so patients who are initially doing well for the first 5 days may suddenly get further deteriorate and be intubated and then go downhill over the next 10 days as a response of both the mix of the virus toxicity as well as the inflammatory response that your body activates for this in the severe stages. Next slide. So
5 minutes left.
Why is it that individuals with this disease get worse? Well, it affects young people and old people, but old people, it does worse at this time. And what we see is you get older, your ability to fight infections is compromised. Older people have fewer CD8 cells that can encounter and fight the virus. Men have fewer than women of this, so women tend to have a better cellular response than men. Some old people do have adequate CD8, but most people in general, as we get older, have fewer cells to directly fight this virus, both T cells and active B cells for this. So this is the problem of a reduced immune response as we get older, and that's why we see deaths in older people. Next slide. What we see here are what are the risk factors that increase the risk of this virus, of having severe disease. Hypertension, obesity, lung disease, diabetes, and cardiovascular disease are certainly risk factors for it. What we see on the bottom right is graphs that show that if you're going to die from the disease, you're more likely to have hypertension in those individuals. Survivors had 10 to 30% had hypertension, where people who died of the disease, it was anywhere from 20 to 70%. So people with hypertension are more likely to be non-survivors and die of this disease. Next slide. The last slide was a single study or trial. This is a recent publication that's coming out today from JAMA, and it shows, again, in up to 5,000 patients in multiple studies, hypertension still stands out as a prevalent associated risk factor for people who are intubated, go into ICUs, or die of COVID-19 disease. And you can see on the bottom that there's a progression of individuals. Hypertension goes up as we get more serious disease, ICU disease, those who in fact die of the disease in the composite. So hypertension is associated with more severe disease for COVID-19, more likely intubation, more likely death with this disease. Is it an independent predictor, or just because older people more likely to have hypertension? We still haven't sorted it out yet, but it's certainly, if you have hypertension, there's more likely chance that you will die from this disease. Next slide. So what makes an individual high risk? We said hypertension was associated with a higher risk of the disease and clearly greater mortalities for it. Does that mean we should stop some of the medicine, the renin-angiotensin blockade medicines, ACE and ARBs for this? No. At this point, there's no indication that hypertension medicine puts you at higher risk. In fact, at the bottom, we see individuals on AR blockers, angiotensin receptor blockers, common treatment for hypertension, have a lower chance of an adverse outcome by about 60% than other people. So hypertensive medicine doesn't put you at risk. It might slightly protect you from the risk of dying of this disease. Next slide. What puts you at high risk as markers? We clearly know a number of cytokines are seen, but the clearest or highest marker that shows that you're going to have a bad prognosis and or die is troponin. Troponin is a protein that leaks out of the heart from the heart muscle. We see it in heart attacks. And if you, in fact, have troponin leak, you could be having an acute myocardial infarction. You could be having another type of cardiac strain from severe hypoxia or anemia, the so-called type 2 myocardial infarction. You could have other events that also lead to strain on the heart and a leak of troponin, including viral myocarditis, where the virus gets right into the cells of the heart and they leak troponin at that time, especially if you have the so-called aggressive immune response, where your immune system starts attacking your heart as well from cytokine storm. So all of those areas can lead to increased troponin. Next slide. And that increased troponin bears an additional risk or prognosis for not doing well. If we look at the columns that are shadowed in gold there, we see that if you in fact have a raised troponin, that you're more likely in the first column to in fact die of this disease. I'm sorry, in the second column that is highlighted for non-survivors is the deadly ones. And you can see that the mortality is as high as 70% in individuals with an elevated troponin. Whereas if your troponin is not elevated in the first column, your mortality is single digit or low teens at that time. So it's going to double, triple, or quadruple your risk of dying of the disease if we see evidence of leaked troponin, cardiac protein, in your blood. Next slide. So what do we do for these individuals with in the coronary or COVID-19 pandemic era with acute coronary syndrome? Well, if you have a regular STEMI or a regular type of heart attack, we have to treat it the same, which is go to the cath lab and have a stent put in at that time for that. If you can't do that, we use fibrinolytic therapy to try to open up that vessel at that time. And we have to be very careful in those individuals in a cath lab to not expose the operators to this virus as you show up in the lab. Next slide. Here is a diagram for that. And what we see is for the COVID-19, if you come in with any evidence of cardiac injury, such as that elevated troponin or chest pain, we have to immediately decide if you're a STEMI, an NSTEMI, and what the therapy should be. And this diagram shows for STEMI patients, a large, moderate or large STEMI, you should still go to the cath lab if it's available in your hospital, and have primary PCI, which is a stent to immediately open the vessel and get recirculation or perfusion into the ischemic myocardium or heart. On the right, if you're having a non-total occlusion, but a significant area of ischemia, a large area of an NSTEMI, non-ST elevated MI, then we're still recommending that you go into the cath lab invasively and open up the vessels needed to reperfuse your ischemic myocardium. However, if you're having a small area of ischemia, then perhaps in a COVID positive patient, we might want to treat you medically at that point in time. And if you're a STEMI patient, if it's a small area, we could use fibrinolytic IV therapy rather than risking going into the cath lab and exposing others. Next slide. So we talked about occlusion of the coronary artery as being a way of putting your heart at risk and dying of in this COVID-19 era. But there are other ways of injuring your heart besides occluding your coronary artery, the garden variety type of atherosclerosis. We know that on this slide, there are on the left ACE2 mediated direct changes. The ACE2 system does modulate your blood pressure and cardiac function, and that can be significantly altered by the COVID virus. If you get respiratory insufficiency, you'll get hypoxia-induced myocardial injury, and that can lead to stress on the heart and the cells, which can cause them to be injured and reduce function. The third column that we see is cardiac microvascular damage. We do know in this disease, there are microvascular injury, both seen as thrombus in the vessel and injury to the endothelial cell. And because your microvascular capillaries supply all of your vital heart muscle, any injury to that microvascular circulation can lead to injury to the overall heart. And lastly, we see systemic inflammatory response. In some individuals, a aggressive inflammatory response to fight the virus comes out, but it targets not only the virus, but your cardiac cells, your endothelial cells, and other organs as well. This so-called cytokine storm can lead to significant damage by itself, which can actually exceed the original viral damage. Next slide. So what makes someone high risk? If you have myocardial injury, we said with troponin, that puts you at very high risk for this disease. And if you detect that early in your patient, you've got to be aware that they're going to have a very, very complicated course and high risk of death. If individuals have low or normal troponin, their risk is significantly less of dying of the disease. Now, because plaque rupture is still possible with any inflammation, we see it with influenza, we have to remember that garden variety atherosclerotic plaque rupture disease, STEMI and NSTEMI as possible, those patients need therapy with a variety of things, including reperfusion, statins, and antiplatelet therapy for that. And lastly, we have to realize taking someone with infection into a cath lab where we're sticking in needles and they're coughing may put the provider and the healthcare system at risk as well. Next slide. Other things to remember is this is probably a prothrombotic disease. So we see strokes with it, and we see pulmonary emboli, and we see arterial thrombi as well. You may be aware that individuals can get COVID toe, which appears to be a thrombotic event rate that occurs in the small blood vessels of the legs or of the toes for that. For individuals, there are who respond with aggressive release of cytokines, similar to the storm we see in cancer patients on immune therapy. We have to realize that cytokine storm or overwhelming the system can lead to damage as well from the high inflammatory burden. We want to fight the infection, but we don't want the inflammation to start attacking our own normal cells at that time. And as we have the virus in the cells of the heart and the cytokines as well, we notice that there are arrhythmias that occur. And of course, some of the therapies proposed for treatment of this disease increase the QT interval. The virus appears to increase the QT interval. We can get proarrhythmias. And we do know a number of these patients have died sudden death from cardiac arrhythmias. Next slide. So how do we fight this disease? Well, we talked about staying away from it, staying more than a micron, like how about 6 feet away or more to avoid contact with the cells. But if you get it, we do know that the SARS-CoV, after it touches the cell within less than a micron, gets into the ACE2. And there are 7 steps that are required for this cell to get into the cell, to in fact penetrate, and then to turn on a manufacturing process, an assembly process within the cell. Each of those 7 steps can be interrupted by an antiviral medicine. And so we're now experimenting with each of those in protocols to see which antiviral interruption of this process can lead to the best results in these individuals. We don't have a lot of time to develop new drugs, so we're using drugs often off the shelf that are there that look like they would be good candidates for interrupting each of these 7 steps. If we can interrupt them, we can perhaps slow the virus and maybe get the patient out of the hospital faster. Next slide. This shows the response we're counting on, which is for your own immune system to, in fact, counteract this virus. On the left is shown the typical early stages where the virus affects a respiratory virus or epithelial cells that then communicates with a dendritic cell that takes that information on the antigen or the virus to your lymphatic system to turn on your B cells and your T cells to make antibodies or cytotoxic T cells for it. On the right, the usual process is shown for that. And what it shows is early on, you're using mostly innate immunity. And that means your your T cells that maybe don't have a memory are required to recognize this as somewhat different and start attacking the cells. On the right, after about 5 days, your B cells have enough time to start considering, making, recognizing, and developing antibodies that come out. And as the antibodies start increasing and your cytotoxic cells are still there, then the virus is overcome on approximately day 10 in this scenario here. So it takes about 10 days to get a full immune response, enough that you can cure yourself or clear your body of the virus. Next slide. And this just shows the process of developing additional treatments that we're looking at. In the center is standard of care, which is respiratory care in many patients, proning to try to get that, and acute and good respiratory therapy for the acute patient. Those who have heart involvement, then we have to add additional things. If we're going to use additional medicines shown here, these have all been shown or in trials right now for the treatment of the 7 steps to prevent the virus from replicating. And the one with the most promise is shown on the top, which we used on our first patient with COVID-19, remdesivir, and it was shown to was at least helpful in that first patient. There is evidence that it does shorten the course of the virus by about 4 days, and a trend towards lower mortality with that. But there are multiple other antivirals that we can use, and we need to see better efficacy in those individuals to prevent deaths and shorten the time for morbidity for this disease. Obviously, on the far right bottom is vaccines. Vaccines so that the herd becomes immune is the ultimate, and those are currently in progress at a number of sites around the world today. There are over 100 vaccines in testing right now. Next slide. And this just shows that one of the protocols for moving to the next stage of this virus is as we open up the community to get out, and we need to be able to do testing and tracing, and so we have to increase that a lot. We're currently able to do a couple thousand tests a day, but we obviously need more for that. We're able to also look at antibodies, knowing whether you've been infected with this disease or not. And those antibodies tests are being developed and available worldwide today as well. That's the future. The future is before you fly, before you go anywhere, you're probably going to be tested. And if you have antibodies and an immune to it, you'll probably get a letter certifying that so that you can then go to different areas. Important for all of our vendors, our travelers.
For some reason, Bill, I can't hear you right now. Bill, I think we've lost your audio. Can others hear?
It looks
No,
like
I can't
Dr.
hear you.
Balmer has been having internet issues. Oh, he is back now.
Okay, Okay, so this just confirms that testing and tracing is our next step. You will not be able to go anywhere in the world or maybe in your community without being tested before you get on a plane, you go travel or you're in fact exposing yourself to the public at this time. And we require 2 types of tests to show if the virus is active, if the antigen is present, or if you have antibodies and you're protected from it. Next slide. So this is now the end of this, and I'm not sure where we are on time, Brian. I didn't hear the chime. Do we have a minute for a question, or should we move on to our next program?
We are just a little bit behind, so I think we should just do the Q&A at the end where we have it scheduled in the 2 to 2:30 hour, just so that we can make sure that everyone hears Dr. Earl. So,
okay, next slide, Brian. So our next, well, actually, the next slide on mine, which was after Q&A, was the introduction for this. Okay, back one. Okay, so now we're going to transition from COVID into telehealth or telemedicine. And why are we doing that? Well, prior to this, we had lots of telehealth or medicine. This just shows a list of the 50 clinics we had for telemedicine that were seeing about 5 to 8% of our patients in the pre-COVID period. Post-COVID, next slide, and we had over 150 publications on telemedicine when we were using it on the upper left for rural cases or isolated cases where someone couldn't come in. Typically on the upper left, a single physician or a healthcare worker is talking to a single patient. That was COVID in the past, or telehealth in the past. But today, post-COVID-19, things have changed dramatically. And what we see is on the right that we're now using telehealth for communication or for conferences like today's conference. On the bottom left, we see telehealth is now being used in our ICUs, where we can now see at another hospital a sick COVID patient. The entire team can be present at our hospital and consulting on telehealth with that other hospital to provide them all of the multidisciplinary care they need for a very sick ICU patient, shown here. And on the right bottom, what we see is another area of telehealth that we'll explore today. And that is, here is an actual COVID patient in the ICU on the bottom right. And you can see that the operator is head covered, gowned, and gloved with a face protection and mask as well, and is administering to the patient, who is intubated on a ventilator, has tubes in, IVs and everything else, and is therefore infectious. What is the individual or the patient doing? He's looking at a monitor. Why the monitor? This is his only contact with his family at this time. So telehealth not only is our way of communicating with patients, it's a way for the patient to communicate with their family. Vitally important these days. If you're in the ICU on a ventilator and you're an elderly person for weeks, you get depressed. If they can see and communicate with their family in real time, and he may not be able to speak to them, but he can nod, blink his eyes, and smile, that's critically important for the family. It's critically important for the patient for that. So telehealth, which used to be for 5 or 10% of our patients' remote access needs, is now 100% for all of our patient encounters, is required and available today. And it's made the entire difference in this post-COVID-19 area. To discuss that, our next speaker, next slide.
I have to say thank you, Bill. That's a beautiful innovation, bringing the family to the bedside. And welcome, Dr. So.
Our next speaker is going to further discuss that. Dr. Earl So is the medical director for the VA Los Angeles Ambulatory Care Center, clinical associate professor of medicine at USC Keck School of Medicine, and he is been involved in this for years in design. He has what you can see here, excellent awards, and is clearly going to give us the very best information about telehealth today, what it's doing, and what is required, because I think many of our viewers are interested as we enter this post-COVID era. How can we implement the best possible practices in telehealth in their practices or their health systems as well? And Earl is going to tell us exactly how to do that. Earl, thank you for joining us.
Thank you, Dr. Bomber. And I just got to say, I'm very envious of your view from your office there. So I've been involved with the VA and with telehealth for a while now. And the telehealth programs at the VA go back to about 15, 20 years now. And there are some newer programs that have been recently developed, and I'll discuss more about those. But I did want to say, when Hattie first asked me to give this talk, it was last month. We were in the middle of this COVID-19 pandemic and trying to sort out how to take care of patients. Now that we're a little bit further down the line, I think the emphasis right now is how do we go forward in terms of reopening up our clinics and our medical centers to patients. It's kind of interesting. We had a discussion this morning about our moving forward program in terms of opening up to patients. And some of the programs who went essentially 100% to virtual care said that they're not going back. They're staying with virtual care, and they have no plans to move back because they could take care of pretty much everything they did before through virtual care. Next slide, please. So financial disclosures, I'm still hoping to report something. So right now I have nothing to report. Next slide, please. So just a little bit more about the COVID-19 infection. It was first identified in Wuhan, China at the end of 2019. Later on declared as a pandemic by the WHO and public health emergency by the US government. The virus named SARS-CoV-2 was previously not seen in humans and is thought to originate from bats. And that's a picture of the horseshoe bat that it's thought to originate from. And it's unclear whether it jumped directly into humans or whether it was an intermediate host. And it's unclear exactly how it got into humans, whether it was through a wet food market in China or through it somehow escaped from a lab. But certainly there's a lot of interest in determining how it actually got into humans. And there's probably a lot of political and economic ramifications and consequences about the true origin. So the illness is called COVID-19 coronavirus disease 2019, has almost reached all countries at this point. I think there's maybe a dozen countries, smaller countries, where it hasn't reached at this point. It's thought to spread mainly through respiratory droplets and contact, although it could be aerosolized at certain times. And there has been some studies that show that people are contagious even before they show symptoms, which is very problematic from a public health standpoint, that you have asymptomatic people who are spreading the virus, shedding the virus, and they don't even know it. So containment becomes more and more of an issue in that situation. And then some of the current evidence show that its infectivity is higher than the influenza, and there's higher rates of hospitalization and death. And next slide, please. So the COVID-19 infection, as Dr. Balmer pointed, it really runs the range from the patients being asymptomatic to very mild. And so some patients do have severe disease. The symptoms usually occur 2 to 14 days after infection. I think the mean is about 5.1 days. And as Dr. Balmer mentioned, there's fever, cough, shortness of breath, chills, myalgias, headache, sore throat. And one that was unusual in this infection is that there's been a reported loss of taste or smell in many patients. And so the COVID-19 infection can cause severe illness in some patients. Those patients more likely to have severe illness, including the elderly, nursing home patients, long-term care patients, males, smokers, and those that have chronic diseases such as asthma, COPD, diabetes, heart disease, those who are immunocompromised, have obesity, chronic kidney disease, and chronic liver disease. Well, if you look at the patients, let's stay on that slide for a second. Can you go back one slide, please? And if we look at the patient population that we see at the VA, about 50% of our patients are over age 65. And many of the patients that we do treat are in nursing home or long-term care patients. We have about 91% of our patients are males. Certainly a high percentage of smokers. About 15% have COPD, 50% have hypertension, 25% have diabetes. So at the VA, we're dealing with a really, really high risk group that have a really high risk of illness and death from the COVID-19 infection. And in fact, our mortality rates for the veterans is about twice of that in the community of those veterans who are infected with COVID-19. So it really is a strong impact of the VA. And what our programs were focused on is really trying to keep patients healthy, prevent spread of infection, and really looking at patients who might be infected early on, trying to make sure that they do well, that if they do, we see any problems where they may be getting worse, to try to get early intervention. So next slide, please. So there is no treatment for COVID-19 infection at this point. There are some experimental treatments currently, as Dr. Barber mentioned. Remdesivir is one of them. At this point, the treatment is mainly supportive and symptomatic. But it turns out there are many patients that have mild disease. They may have minimal symptoms or very few symptoms, and a lot of these patients can recover at home and do well at home. The problem becomes is that many of patients will, or some of these patients will get worse over time. And it's thought that the second week of illness is when patients may have the cytokine storm and may actually get worse during the illness. And, patients who are initially doing well can get worse very quickly, and really trying to identify these patients and trying to make sure that they get the appropriate treatment is key to their survival, and they're doing well with this disease. COVID-19 testing is another issue. Initially, it was very limited, and depending on the institution, there really were protocols as to who would get tested. And for the most part, initially, it was mainly patients who were hospitalized or sick enough to be in the hospital or go through the emergency rooms and who were sick enough there who were tested, which mainly, I think there was some difficulty in determining how do we treat patients who we don't test, those patients who would not qualify for testing, but who may be infected with COVID-19, or they may have another respiratory infection, flu or cold or something else. So I think, all of these patients, those who were tested positive, those who were not, we're at risk for getting sicker at some point. And so the question becomes, how do we monitor these patients? How do we make sure that these patients get the proper treatment? And next slide, please. So this was the CDC's guidance on testing. Initially, I think most places, including the VA, we were only testing those priority 1 patients, those patients who are hospitalized, sick enough to be in the hospital. And we are also testing healthcare workers. We've currently expanded to priority 2 patients, basically those patients who have symptoms are at higher risk, having age or one of the chronic diseases, or being a first responder or living in some type of long care group facility. The County of LA at this point has opened up testing to basically all patients, even those that are asymptomatic. So we're currently, some of our patients that we're not able to test at the VA, they're currently being tested at the LA County facilities. So next slide, please. So this was our algorithm initially when we had a patient that came in with symptoms. What do we do with these patients? Well, basically when we had very limited testing, basically those patients who would go to the emergency room could be assessed, and basically those were the only group of patients that we test. So this really gave us a large group of patients where we did not test. So basically we had them isolate at home, quarantine at home, and we basically did try to follow them during this period of time. And the way that we did this was mainly through virtual means. Certainly they were isolated, and we wanted them to be connected to healthcare. At the same time, we did not want them to be possibly exposing other patients, other healthcare staff. So next slide, please. So some of the timelines. So on March 19th, the VA authorized the use of non-public, non-VA IT equipment along with programs for the use of clinical activities. So the VA had some foresight into recognizing that we were going to be delivering most of our care through virtual means. Well, even at the VA, even though we've been doing some of the telehealth, some of the virtual care for years now, we really weren't set up for doing the majority of our care through virtual means. And this means that we didn't have their server capacity, the bandwidth capacity to accommodate all the clinical activities that we would be using through things such as video medicine. So we did open up the use of other programs such as FaceTime, Skype, Facebook Messenger, and one of the newer programs, which is Doximity, for the use of video medicine. So on March 20th, the VA basically directed all primary care appointments to be reviewed and converted to virtual appointments if appropriate. And then this was followed by the VA directing all outpatient clinics, be it primary care, mental health, specialty care, to be converted into virtual modalities as much as possible. So we actually started doing this a little bit before the VA timeline and switching all of our patients over. And it did mean that we were calling all of our patients and just trying to assess their needs at that time to see if they really needed to come into the clinic or whether we could take care of them through virtual means. So next slide, please. So the VA on March 27th created a really comprehensive COVID-19 response plan. And the goal was to maximize virtual care and telework for the employees. The goal was also that switching over to virtual care for most outpatient care and protecting our veterans and our staff from acquiring the COVID-19 infection, along with providing care for those with COVID-19 infection, along with providing care for our regular patients, our regular non-infected patients. So this really meant changing, overnight, really changing the bulk of our business and really using communication technology and changing over, to virtual care. In many of the medical centers, they really created two zones of care, a standard care and a COVID-19 area of care to really isolate the COVID-19 patients from the other areas. And we weren't quite sure what this pandemic would initially look like, so we really needed to prepare for surges in healthcare demand. And that meant really discharging patients from the hospital as much as we could, delaying all routine care, all routine elective surgeries, and delaying those as much as we could. And next slide, please. So we also faced the same problems that most places faced, which we really did not have a lot of personal protective equipment. We ran into shortages very quickly. The hospital beds, we needed to make sure we had adequate hospital beds to accommodate the surge in COVID-19 patients, along with the ventilators and the morgue capacity. And we need to recognize that there might be multiple waves of this pandemic. So even though we were prepared for this session, we weren't quite sure when the next wave would hit us, and we need to be prepared for when that occurred. Another issue is that we need to prepare for a reduction in healthcare workforce. The estimates were up to 50% of the healthcare might be out at one time due to illness, due to quarantine, due to employees having to take care of their families, and also those who might be at higher risk, those who might be pregnant, those who might be medical compromised themselves. Those employees who might have some certain medical conditions. Certainly, we don't want them to be possibly exposed. There were several public health measures, such as closing schools, that really also caused a decrease in our healthcare workforce. Many of the staff had children, school-age children, that they had to take care of, find a way to take care of now. So what we're dealing with is that we do have many of the healthcare staff that were at home, and some of the healthcare staff were able still to perform their duties, but yet physically they were stationed at home. So we really try to turn to telework and telehealth as much as possible to try to keep them productive and actually help them with the workload that we had. The other thing that the VA prepared for was really to support the local community healthcare resources. In many of the cities throughout the country, the VA served as a safety net for when the hospitals were overloaded. And many of the VAs throughout the country, such as in New Jersey, New York, New Orleans, they started taking COVID-19 patients into the ICUs, which were non-VA patients. Also, many of the healthcare staff help support some of the other non-VA healthcare facilities. Like in Los Angeles, we have a group of nurses who are currently supporting non-VA nursing homes and providing care when many of the staff at the nursing home became ill with COVID-19 and weren't unable to work. So next slide, please. So the CARES Act was passed in March 27th, 2020. It provided 2.2 million economic relief. And part of this did include additional money for telehealth. There was 17 billion that was allocated to the VA to really try to meet the needs of the COVID-19 infection. And part of this was earmarked specifically for the use of telehealth services and to enhance the services available, and especially mental health services, where it was targeted as an area that needed additional support. So next slide, please. So the CARES Act also provided funding for community resources for telehealth. Part of the CARES Act included money for a COVID-19 telehealth program that was money available, that was grants available to other community healthcare providers to provide telehealth, telecommunications to their patients. And there was also a connected care pilot program, which was trying to determine what were the best ways to try to deliver some of the telehealth modalities that were to the areas being served. Next slide, please. So why telehealth? Telehealth actually fits in well in terms of solving some of the problems that are occurring with this pandemic. We're able to maintain social distancing with telehealth. With telehealth, we're able to do a triage of patients before they even come in. We provide a sorting of patients, and we actually could direct patients where they should be. And by doing that, minimize exposure to other staff, other patients. So we're able to get the patients to the place that they should be and prevent, patients waiting in the waiting rooms or the emergency rooms and the urgent cares. With telehealth, we're also able to provide for care for patients who are under self-quarantine, self-isolation, and able to monitor these patients and follow them closely. And for patients who are discharged from the hospital, it's the same thing. We are able to follow them closely. With telehealth, we're able to maximize our workforce potential. We have many of our healthcare staff that's actually working at home, performing telehealth, doing video visits, doing other types of visits from home. At this time, we're also able to provide gap coverage in certain areas. I mean, telehealth does lend itself to that when certain staff, and maybe in certain other areas of the country, are short, we're able to provide coverage to that area. And with this pandemic, we had to actually repurpose some of our clinical space to accommodate different uses for the COVID-19 infection. So when we had space that, clinical space that where the staff was doing telework, we could use that space for such as isolation rooms for certain patients that may be coming in with the possible COVID-19 infection. And with telehealth, there's less PPE use, which is short all the way around. Next slide, please. So why telehealth? Certainly it's patient-centered. It's convenient for the patients. There's reduced transportation. It's accessible to almost all patients. It really supports delivering the right care at the right time. And it helps coordinate care across the continuum. With telehealth, we could coordinate care through multiple areas, multiple specialties with the patient's care. And it also helps us coordinate care with the patient's caretaker. Family members, caretakers also can be a part of the telehealth programs. Also with telehealth, we have a larger focus on patient education, patient self-management of their illness, and also having them perform more shared decision-making. Next slide, please. So also with telehealth, we have more older patients living longer. And with the increased longevity, we have increasing rates of chronic disease. We also have a higher expectations in healthcare. More patients are expecting as much as possible, really, that we give them the latest, the greatest in terms of treatments. Also, with these advances in technology, we're able to monitor more, able to do more with telehealth. And next slide, please. So with telehealth, we have seen some of the VA data does show improved health outcomes, including reduced ER use, reduced hospitalization. I think the VA data shows about 25% reduced hospitalization, about 20% reduced ER use with the telehealth programs that we have. Some of the data also shows reduced length of stay. And with all this, with telehealth, they're able to capture all the data, all the healthcare measurements that go along with this. And we did mention that with telehealth, there was a reduced cost, physical cost of maintaining physical space, parking lots, infrastructure, buildings. So there's a reduced cost overall with telehealth. Next slide, please. So these are most of the, I'm just mentioning most of the VA telehealth modalities that we have available at this time. They include telephone care, secure messaging, VA Video Connect, the Annie-App, and care coordination. So let me explore each one of these a little bit more in depth. Next slide, please. So with telephone care, I think everyone's familiar with having a telephone visit. Certainly this is the easiest way to provide virtual care. This is the lowest technology that is required, no really special infrastructure or equipment besides a telephone from the patient's perspective. And we really target this for patients who have been able to use other forms of telehealth, able to use the video visits, patients who may not have a smartphone, may not have high-speed internet at home. With telephone visits, though, this is something that can be easily scaled up. You easily implement this on a large-scale basis, and this is something that most medical centers did with this pandemic. They switch over to telephone visits. So next slide, please. So with the telephone care, we also have call centers that are available for the patients. We have two different types of call centers. One is a more of administrative call center where patients mainly use to leave messages and make appointments, maybe request medication refills. And then we have a clinical call center where patients come in and really they may present with different symptoms, may ask for advice from the triage nurse who's manning these phones about their symptoms, about what to do. And so with our telephone care, we are asking our patients, we have been asking our patients really to call the VA first before they come in, so we could try to direct them to where they should be and try to give them the proper care with the least amount of them having to go through different areas of the medical center. So with this, we're able to provide a warm handoff to the clinical call center when needed, And the RNs there, the NPs there are able to provide additional triage and additional treatment over the telephone. For those patients with possible COVID-19, many of them, depending upon their level of acuity, are asked to remain at home. We give them instructions about what to do, how to follow up, and how, when to come to the VA facility for additional care. So we do have separate areas in the emergency rooms, in the urgent cares, to try to treat the COVID-19 patients. Next slide, please. So the other thing that occurred with telephone care is that not only did patients call us, but we called them proactively. For those patients who are at high risk, we did try to reach out to them and basically screen for COVID-19 infection for those patients who had high risk medical illnesses. So those patients who had CHF, diabetes, COPD, so we reached out to them and basically instructed them what to do in case they do get sick, how to seek care, along with asking them about their illness, how they were doing with their illness, whether they needed medication refills. That was a big thing for many of the patients who are no longer coming to the clinic, to make sure that they had adequate medication refills. Another thing that we were doing at the VA for a while is that whenever a patient is being discharged, we do try to contact them within 48 hours of discharge. And basically this is a checkup on them to see how they're doing, to make sure that they're not decompensating, make sure that they were discharged without their proper medications, and just to see whatever other care was needed. With this outreach, we're also trying to reach out for those patients who may be at high risk for other things. High risk, certainly with many of the veterans, they may have suffered from mental illnesses. They live alone, so some of them are at risk for having isolation, and we do try to reach out for those patients, and along with those patients who might have other needs. So those patients who were homeless or are at risk of being homeless, to make sure that they're doing okay. Yeah, next slide, please. So for the wellness checks, they included doing a medication reconciliation for their high-risk patients. For our heart failure patients, we did try to review their daily weights and make sure they were taking their weights accurately. For our COPD patients, we did ask about their inhalers, where they had adequate inhalers, and to making sure that they were using them properly too. For patients who are with diabetes, we're trying to outreach for all of our high-risk diabetic patients, poorly controlled diabetic patients, seeing if there were any medication changes that were needed, and also referring them to the dietitian, the health coach, the pharmacist as needed for other virtual visits. For our patients with hypertension, poorly controlled hypertension, we did try to make sure patients were monitoring their blood pressures on a regular basis. And we did offer patients home BP monitors, if appropriate, for them to check their own blood pressures. And for all of our patients, we did try to educate our patients on the use for video visits, because certainly we want to try to move to that modality as much as possible. So next slide, please. So at the VA, we do have certain registries that are available for us from our electronic medical record. On the right-hand side, we have a CAN score for patients. Our CAN is Care Assessment Need score. So these are patients that are high risk, that have been hospitalized or in the emergency room multiple times over the past year, who have certain illnesses that are considered to be at high risk, such as CHF. So these are some of the patients that we reach out to. And another registry that we do have is a medication report, looking at those patients who may be an outlier in terms of getting their medications refilled. So those patients with diabetes, ischemic heart disease, or hypertension, making sure that they had adequate refills on their medications. Next slide, please. So this is what happened during the month of March, when we really switched over to virtual visits as much as we could. So the blue represents face-to-face visit, the orange represents a telephone visit, The gray that you don't see a lot of are actual video visits. So for the most part, we moved over to video visits. We did try to move to, we moved over to telephone visits. We tried to move over to video visits as much as we could, but actually we experienced the problems that were anticipated by the VA earlier. We did experience problems in the server being down, bandwidth issues. So we experienced really a myriad of issues with our video visits. And because of this, much of our care was switched over to telephone visits initially. I think right now we are getting more bandwidth capacity with our video visits, and I think those numbers are starting to go up more now. So at the VA, it looks like our caseload in terms of clinic visits dropped to about 2/3 to what it was pre-COVID-19 pandemic. And so we maintained about 2/3 of all of our visits, all of our encounters for visits during that time. And this compares to some of the other community medical centers. I think the close university medical center, their caseload, their clinic caseload dropped to about 1/3 of what it was before COVID-19. So with our virtual modalities, we're able to maintain much of our workload. Next slide, please.
Dr. So 20 minutes left.
Okay. So another thing that we do for our telephone care is that we have a tele-tuck-in program where we have a call center nurse who calls our patients during our off hours or maybe on the weekends. Those patients who might have been discharged from the hospital, might have been seen in the ER recently, and basically to follow up on these patients to make sure that they're doing fine and really just to decrease any bounce backs to the emergency room. Next slide, please. So secure messaging, this is our email modality that we use for our patients. It's a secure method of emailing our patients. The one thing that we have been using this more and more for during our COVID-19 patients is that since many patients can't get into dermatology and some of the other areas, we're asking patients to give us high resolution photos on this platform so we could see what's going on with if they did have a rash, or just the other day a patient told me that he had a red eye, and I asked them to take a high resolution picture to send it to me, and it turns out it was a subconjunctival hemorrhage, which is a benign condition. Rather than him having to come in and be seen, we took care of it during this method. So next slide, please. So VA Video Connect, this is our video program that we use for our patients. It allows a video visit with our patients, and it does allow other team members to be involved on the same call, along with other family members or caretakers. Next slide, please. So this is an option for our patients. It's similar to FaceTime and other video programs. It's fairly easy to use. It does require downloading an app on Apple devices and then clicking on an email link. Some of our elderly patients does need some hand holding to try to get them to use this the first time around. But for many patients, it's fairly intuitive and easy to use. Next slide, please. So we do a myriad of different things with our Video Connect visits, including follow-up visits for the patients, for simple things, for patients who don't have necessarily complicated problems. One nice thing is that we do get to assess the home situation for many of the patients. We get to see what their home situation is like, and to see if there's any unsafe conditions that we might spot, that they may be hoarders, they maybe have things piled up high, there may be unsanitary conditions of some of the patients. So it does allow us to see that. Certainly, and with the pandemic, this is works well for patients who are quarantined at home and would be a risk for possible infection if they went outside. Dermatological complaints and wound checks. One of the problems with Video Connect is that the resolution is not as high as people would like, and so that's why For very high resolution things, probably is not the best use of video visits. Next slide, please. So we also use it for follow-up appointments, for other things such as discussing durable power of attorney, advanced directives, triaging patients for new problems, wellness checks, post-hospitalization follow-ups, and screening and following patients for coronavirus. Next slide, please. So where Video Connect is not appropriate, really wherever a physical exam is critical or you really need to see the patient to do something, that those patients we still need to see. So next slide, please. So there's a protocol for use that we follow when we get verbal consent, when we confirm the location of the patient, make sure it's a safe and private environment. We review the risks and benefits of using video telehealth with patients, and along with we discuss emergency plan, just in case we have patients that have an emergency during the visit, patients who have either a medical emergency, or some patients may have a mental health emergency, say that they're suicidal. So we do want to have an emergency plan in place. And the decorum, we ask that they be fully dressed, no smoking involved. I'm sure everyone has heard stories about people who had a video visit and didn't realize that the camera can show, your body below the waist at times. So next slide, please. So this is a typical workstation that we utilize. We use 2 monitors. One monitor is with the video of the patient there, and we utilize the second monitor usually with the patient's chart opened up. We do need sound and headphones, speakers, microphone, the webcam. We need all of those equipment as part of our setup. Next slide, please. So when video adds value over telephone, certainly early assessment of symptoms, developing rapport with the patients. We could get multiple caregiver input. Certainly certain things that we could be assessing through the video visit, such as a patient's alertness, their ability to speak in full sentences, or whether they can only speak in a certain number of words, how they look physically, whether they're diaphoretic. Certainly we have other clues as to whether they're in pain. And we can get feedback with the patient if they can take their own blood pressure using their own blood pressure cuff, take their own temperature. We could get feedback on with those measurements. Next slide, please. This is a video that tells us more about the VA Video Connect.
I think there's a lot of anxiety right now related to the coronavirus. We're hearing a lot in the media about concerns, and we're rapidly changing our everyday behavior from local behavior of not going to large events to stopping travel internationally in some instances. So I think there's a lot of anxiety for veterans about how we're going to stay safe and what healthcare delivery options exist to maintain that safety. A lot of people are concerned that when they come in to be seen, could they be exposed to the coronavirus while they're in the waiting room? So how are they going to get the care they need while maintaining safety? One of the ways that the VA has approached this issue and is really ahead of the curve is with something called VA Video Connect. So VA Video Connect is an innovative healthcare delivery technology that the VA has to make sure that during healthcare crises like the coronavirus outbreak, we're able to maintain business as usual. In fact, we're able to care for veterans in a very convenient way where they're able to maintain the location that they're currently in, either at home or wherever they may be, as long as they have cellular or internet access. We're able to actually have a clinic visit remotely through this telehealth or telemedicine technology called VA Video Connect. All you have to do is call your primary care team and request a VA Video Connect visit. This would allow you to have a visit from your home and have your needs addressed remotely at your convenience. A lot of veterans are asking a question of whether VA Video Connect could actually help screen for the coronavirus. And the answer is yes. In fact, we highly recommend that if you're concerned that you may have the coronavirus or have symptoms related to it, that you call your primary care team and schedule a VA Video Connect, and we are able to screen you for the potential symptoms and risk factors associated to best identify the most effective delivery of care for you to get treatment that you need. For veterans that are interested in downloading the VA Video Connect app, if you have an iOS system or an Apple smartphone, you click here to download the app. It's called VA Video Connect, and it'll show up in the App Store. If you have an Android smartphone, you don't need to download an app. You just need to make sure that you share your email address with the VA, and you should have access to it from your smartphone. The VA created VA Video Connect because the VA cares about veterans and wants to make sure that they are provided the highest quality care in the most convenient way possible.
Okay. Let me try to answer some of the questions while this video is completing. So what protocol is the VA following regarding obtaining routine labs? So we try to delay obtaining routine labs if possible. If the patient is coming in for something else, certainly that's a time to go ahead and perform the labs. But for routine labs, we are trying to delay those until we open up to the clinics again. And then for the telehealth visits, is the provider located at the clinic or in their home? Both, really. We have providers that are in the clinic, and we have some providers that are working from home. So the other thing, I think Dr. Balmer mentions that we are using video health for patients who are in the hospital in terms of those patients who might be in isolation, to try to connect them with healthcare team members along with family members for they can communicate with. Actually, at the VA, we actually asked our staff to voluntarily give back any iPads that they had because our isolation rooms were not set up for video visits. So many of the staff, including myself, we gave back our iPads, and they were repurposed to put in the isolation rooms for video connect with the patients. So again, this helps reduce our possible exposure, reduce our PPE face-to-face with the fact that we can't do a physical examination. So I think overall providers are very pleased in using this modality. Again, it's not for in all cases, but certainly there's many things that can be done through video with the patient. Next slide, please. So this is our newest telehealth modality. It's the Annie app for veterans. Next slide, please. And this was named after Annie Fox, who actually was the first woman who was given a Purple Medal. She was a chief nurse over in Pearl Harbor. And some interesting trivia, she actually had their Purple Heart retracted because they changed the criteria for the Purple Heart during that period, that Purple Heart was only to be given for somebody who was injured while serving on duty. And she, even though she was exemplary in terms of her leadership and her work ethic and her standing work that she gave during that period of time, the Purple Heart was actually retracted from her, and she was given a different award, Bronze Star, instead. But now she gets the, I guess, recognized with this Annie app. This is actually similar to an app that the United Kingdom uses. They, in the National Health Services there, has an app called Flow after Florence Nightingale, which is a similar type of app. So next slide, please. So this is a app where patients use, and really it's a text message app, where patients will receive text messages that's related to their health care. That may include reminders, may include motivational messages, may include general messages from the healthcare center. And so this really it is built around specific illnesses that patients have. So a patient may be assigned an app for hypertension or diabetes, and really this will give them text messages regarding their illness, and they could input certain information, and it'll keep track of that information in the program. So next slide, please. So we can also broadcast messages, blanket messages throughout everyone who's using this app, such as flu shots are available, a handy way to communicate with patients. And so messages are stored into the system where patients can review it, along with the clinician can review it. Now, this is not a real-time app for the clinician. It doesn't notify the clinician regarding things that are being stored there. So it's something that really is stored there for use in later time. And this is just an example of some of the protocols that are available with this app. We now have the COVID-19 app, which will help the patients monitor for any symptoms, assist them with trying to find out who to notify, where they should seek additional care. This protocol is 2 months long, and basically they get 10 prompts per week. We also have tobacco cessation, weight management, oncology systems reporting. This one I think was kind of interesting because it's reported to have have improved survival in cancer patients. So that was kind of interesting. And there are additional protocols, along with clinicians can develop their own protocols for use. Next slide, please. So this is just an example. Yes.
10 minutes remaining.
Okay, this is just an example of what the provider may see in terms of enrolling their patients. Next slide, please. And this is an example of what the patient may see in terms of text messages. Sorry, this is not very easy to read. Next slide. We'll show the video that shows a better example. So this is just a graphing of the data that's put in by the patients. The patients can see this, clinician can see this. Next slide, please. And this might be a video.
Remembering everything you need to do after your VA appointment can be overwhelming. That's why the VA has developed a new tool to help you keep track. Meet Annie. Annie is an automated messaging app that uses instructions from your doctor to help you stick to your personalized care plan between appointments. Annie sends reminders and other helpful messages directly to your phone or other devices. Respond to Annie with a simple text or through the Annie app. Your responses are available for you and your VA care team to review at any time to track your health goals, encouraging you to take an active role in managing your health. Remember, Annie helps you record your health, but is not a way to message your doctor. If you need to send a secure message to your VA care team, please continue using My Healthy Vet. Talk to your provider today to see how you can use Annie in your care plan. To learn more, visit the Annie app for Veterans page in the VA App Store.
Okay, go move on to the next video.
After my last physical, my doctor and I came up with a plan to help me stay healthy. I wanted to make changes that would help me lose a few pounds and keep my blood pressure under control. At first, I was a bit overwhelmed. Fortunately, I have Annie to help. It's a mobile phone-based messaging tool designed just for veterans. My provider uses Annie to connect me with a care plan that helps me manage my condition. Even though I don't have a smartphone, Annie can send me messages. And I can send Annie data about my vitals that my provider and I can review at my next appointment.
When my doctor told me I had diabetes, I worried that I have trouble knowing what to do. Annie sends me tips and reminders about how to manage my diabetes. And I can always contact my healthcare team if I'm concerned or have questions about my readings.
Annie is great, and the messages and reminders are really helpful. But they're no substitute for regular contact with my healthcare team. So when I don't feel well, or if one of my readings stays high, I contact my healthcare team right away.
Annie is free to all veterans, but depending on your cell phone provider and plan, you may be charged for the messages you send and receive. Take a more active role in your health. Ask your healthcare team about how Annie can help. And download the free Annie app from the VA App Store today.
Okay, next slide, please. So this was a flyer just promoting the use of Annie and COVID-19. And next slide, please. So we use Annie app for our low and moderate risk patients. And let me just give you an example of some of the things that Annie asked for regarding COVID-19. Next slide, please. So the Annie may, on a daily basis, will ask the patient, first of all, what is their temperature? And the patient may put in the temperature. Next, they may move on to the cough, whether they have a cough or not. And depending upon how they do on that, whether they have breathing issues. And certainly if these are positive, if a certain, there's a trigger that basically asks the patient to seek additional care. So next slide, please. So the Annie app does also give patients motivational and educational messages, such as remembering patients to wash their hands, to cover their cough, basically to make sure that they don't get isolated, don't get too lonely. Next slide, please. So the last modality I wanted to touch on was our care coordination home telehealth. So this is a program that's been at the VA for about 15, 20 years now. And this is really our remote monitoring program where patients, we're able to monitor our patients with different equipment and with a patient at their home. And this is through a device that we give to the patient. Currently, the newer devices, they have voice with the interactive response, which makes it a lot easier to use. So the next slide, please. So this is an example of a patient using the device. We have nurses who are called our nurse care coordinators who are at the other end, receiving end of this information, and they will monitor this patient on several times a week, daily if needed, depending upon the situation, about the information that is being input by the patients. Next slide, please. So these are some of the devices that can be connected to the main device, including a peak flow meter, glucometer. For the COVID-19, it's especially important to have a pulse ox, thermometer, but for some of our patients, blood pressure cuff, weight scale, pedometer, stethoscope. Next slide, please. So some of the illnesses that are monitored with our care coordination home telehealth, mainly chronic diseases, poorly controlled diabetes, congestive heart failure, poorly controlled hypertension, COPD, mental health diseases, depression, PTSD, weight management, substance abuse, and now COVID-19, presumed and confirmed COVID-19. Next slide, please. So there is daily monitoring. These devices are set up at the patient's home. And the patients enter the information through a monitor. And this is all recorded, all sent to the care coordinator, and they review the information. And if anything is out of whack, basically it triggers an alarm, and the patient, the nurses will review and take intervention at that time. Next slide, please. So the care coordinators do review with the patients what devices are best suited for them. They train the patient, they get them set up. Some of the interventions that occur, basically self-care, informing the patients of their conditions, helping the patients manage their own conditions, arrange any type of treatment changes, including medication changes that occur. We do have NPs that also are part of this program, so they're able to titrate medications for certain illnesses. Contacting the patient's provider, when needed, having the patient go to the ER, or if their condition destabilizes. So next slide, please. So for an example, for our diabetes protocol, Some of the questions that may be asked is, do you have any new sores on your feet or your legs? Are you taking your diabetes medications as ordered? And basically, this feedback is all given to the nurse to review. Next slide, please. So for COVID-19, we have a 21-day disease management protocol that we're currently using. And veterans can be enrolled in this program at different points of care, from the emergency room, from the clinics. We can enroll patients into this program where they could be at home, being isolated at home, and we could continue to monitor them. Yeah, next slide, please. And so what they are monitoring vital signs, temperature, pulse ox, symptoms. They are reinforcing their quarantine status, and along with giving them education on hand washing and infection control. And also important how and when to access additional medical care. Next slide, please. And we also have, this program also gives us, has a low acuity telehealth program. Same type of system, but we have patients who are not as acute as part of this program. There's less frequent monitoring. For these patients who are not as sick, we offer them that this is an option for care. So next slide, please. I think this is the last video. And this is a newscast out of Texas.
Local veterans now have access to convenient health care. It's called Telehealth care. It's available to any veteran with a chronic condition that's registered with the VA. Rachel Ripp joins us with more. Rachel.
Crystal, the VA's budget for this year includes an allotment of $1.1 billion for telehealth services. This is a $105 million increase over the 2019 budget. As technology advances, the VA has more and more opportunities to shape the future of healthcare. This is Kenneth Turner. He is a Vietnam veteran living in Big Spring. He lost one of his legs to chronic diabetes.
The next thing I know, I ain't got no leg.
Through the VA home telehealth care system, he's been getting checkups every day for the past year.
Press start to check your oxygen saturation.
Number one, it saved me a lot of trips to the VA. And then two, if my sugar is high or low, when I contact Lewis, he can tell me what I need to do, what I need to take. If I'm doing too much sugar intake, too much cholesterol. I wish you a great day, and thank you so much for letting us help you. Thank you for your service.
Lewis is Kenneth's assigned nurse care coordinator. He can call Lewis in the Odessa clinic through his monitor anytime there's a problem.
This morning, my sugar was a little high. I'm going to get a call from Lewis. Why your sugar high? He want to know. That's called care.
Your data is being transmitted.
Care that comes every day.
This little machine here works miracles. They tell you everything that's wrong with you.
Kenneth is one of about 200 veterans using this program. So how does one qualify for this kind of health care? There are 3 criteria. You must have a chronic condition, you must have all your medications provided by VA pharmacies, and you need to be in follow-ups with your VA doctor. Lewis says this program creates a close link between the veteran and the VA.
Always start slow and grow into your physical activity.
The call monitor and all the equipment specific to the patient is shipped directly to them. Once it's delivered, the VA calls and assists with setup. The system is user-friendly, but if they have any questions, there's also a book provided to them. Care at their fingertips. If this program is something you are interested in, be sure to have a conversation with your VA primary health care provider. And if you aren't registered with the VA, you can go to our website. We have all the information you need there, or you can walk into any VA clinic in West Texas. And these clinics say even if you've been denied in the past, it's never a bad idea to try again. Crystal?
All right, next slide. So this is just a flyer that we offered our patients regarding our virtual care modalities that patients can access from home. And next slide. So last slide. So with telehealth, really the advantage is we have the ability to screen and monitor patients remotely. We're able to provide routine care for chronic diseases. We reduce the exposure to staff and patients, along with it helps us meet our resources with the demand. Some of the limitations, there's still equipment that needs to be obtained, bandwidth issues, that happens to be a problem, often with the patient in terms of their internet access. The ease of use of technology, as the technology gets more and more advanced, it gets easier to use. So many of the programs that we have nowadays are very, very easy to use. And certainly doesn't eliminate the need for in-person evaluation, such as testing during this pandemic. So last slide, that's it. Yes. So thank you very much.
That was great, Earl. I am totally impressed at your videos and your presentation and everything else. I want to sign up for Annie right now.
Okay.
And I actually have hundreds of questions for you because I think it is impressive. And there's a lot of things that I'd like to know. I think on the basis of we're about a half hour overtime right now, let's hold the questions until the next speaker. And then if you're still available, I'd like to ask you things about the program. You have more money, more video, and more capability than we have. So I'm totally impressed. Could I ask to proceed to the next slide? So the next speaker I thought was Marilyn Stebbins, but are we going to do it skip one or not?
We will have Rose Pavlakos go first.
First, okay. So
Yeah,
there's
Marilyn said that she would hold off until next time in the interest of time.
I see. Okay, a change ongoing. So as the COVID-19 evolves, so does our program today. I'm delighted to introduce Rose Pavlakos, who is a pharmacist at UCSF, and she has certainly worked hard to do that. And I think she's participates at UCSF in the Cardiovascular Care and Prevention Center, certainly an important area for any hospital and any healthcare system. And her focus is on medication management, critically important for our involvement of our patients, transitional care, chronic care management, and working with the cardiology team. We welcome a very experienced and talented team member, Rose, to our talk today. Rose?
Hi, and thank you for having me. You can go ahead and go to my first slide. So today I'm going to give a summary on the telepharmacy services that we provide within UCSF's outpatient cardiology clinics. And then we'll discuss a little bit about our transition to completely remote work due to COVID-19. And we'll also share some information on the tools and platforms that we've found useful and helpful in making this transition successful. So go ahead and, oh no, I'm sorry, stay on this slide. Yeah, so I'll go ahead and start by talking about the various clinics that we have throughout the city. So as you can see, we have 7 different cardiology clinic sites throughout the Bay Area, all providing different specialty types of services. We now have 60 cardiology faculty, and we serve over 17,000 patients. And we have a very diverse and extensive multidisciplinary team. We now just added on a psychiatrist in our cardiac rehab group. We have a registered dietitian that works with our prevention group. We have nurses, nurse practitioners, fellows, clinical fellows, and just a huge group that we work with. And I think that that has really helped us lead to our successful services that we provide here. So go ahead and go to the next slide. I'm going to now introduce you to our pharmacy team. So we now have 2 clinical pharmacists working throughout those 7 clinic sites. I spend most of my time in general cardiology, but I offer my services to all the specialties throughout cardiology. And then our second pharmacist spends 1 day a week in our prevention with our prevention group, and the second day a week with rehab. And we have a full-time pharmacy technician who helps us, in addition to 1 to 2 pharmacy students each day, a pharmacy resident, And we just received a small grant to work on an interdisciplinary learning experience with adding on medical students so that they can learn alongside our pharmacy students and pharmacy residents. So we hope to start that pilot project this year. Next slide. So I'm going to go ahead and give you a summary of the various pharmacy services that we provide. So the number one thing that we receive referrals for is chronic disease state management. So we help with getting our patients' blood pressures and lipids under control, as well as making sure that our patients are on optimal medication therapy for their heart failure. We also help with polypharmacy related issues, medication therapy management, transitions of care, anticoagulation bridging, medication access issues. So a lot of our patients have difficult time affording their medications, and so we'll help them get on patient assistance programs or provide them with coupons and various other means to help them get access to their medications. We also deal with any medication related side effect that comes through our call center. We answer drug information questions for our providers, help with drug-drug interaction related issues, and we have a Medicare Part D enrollment service that we offer during Medicare open enrollment each year between October 15th through December 7th to help patients save money on their medications by making sure they're in the right Part D prescription drug plan. And then of course, our pharmacy technician who spends most of her time working on prior authorizations for our cardiac medications. Next slide. So I wanted to just give you a bit of a summary of kind of how our schedule works and the referral system works for our pharmacy services. So essentially, a patient comes in to see their cardiologist, and this is pre-COVID times. A referral is placed to the cardiology pharmacy service for any of the above services that we just discussed. And ideally, I like to have an initial consult in person with them for my first visit, just so that I can get to know them, make sure that I go through their medication bottles with them and understand how they're taking their medications. I like to do a full medication therapy management review, which means that I look through their medication list and I identify whether or not all of their medications are actually indicated, if they're effective, if they're safe, and if they're adherent to their medications. And then in addition to that, before sending them off and doing remote telehealth services, I like to make sure if we're having them use any home monitoring systems, that those home monitoring systems are working well. And so I'll have them bring their home blood pressure monitor in, and we'll double check that before we make further medication changes based on those home readings. And then typically, the rest of their follow-up visits are done via telephone, and they're scheduled on a weekly, bi-weekly, monthly basis, depending on patient-specific needs. And we can go ahead and move on to the next slide. So as you can see here, about 90% of my services are telehealth. It's just that initial visit that I like to see them in person. And so now I'd like to share with you some of the projects that we've worked on throughout the past few years that our pharmacy team has participated in. So the first one will be our hypertension study. So within this project, we helped to develop a mobile health platform that was later tested to evaluate the clinical feasibility of using a mobile health platform for hypertension management. Our goal was to develop an interprofessional approach to improving the quality of hypertension management that was being provided to our patients in cardiology. As you all may know, a typical cardiology follow-up is scheduled at 6 months out from their past visit. And so by adding on the pharmacist, we were able to provide more rapid medication adjustments and follow-up. And so we provided this service to 120 of our patients, and all of our patients were given a home Omron blood pressure cuff. And then during onboarding, our patients downloaded the smartphone app and were educated on how to use it. And then the app itself scheduled blood pressure reminders and allowed for virtual communication via direct messaging, similar to the system that our last speaker was describing that they have at the VA. We also had a health coach that was accessible to our patients to help regularly engage with patients and then triage the urgent issues to myself or the cardiologist when necessary. And the pharmacist would perform weekly or biweekly follow-up and collaborate with the cardiologist to make medication adjustments, plan for lab monitoring, etc. And what we found is that with rapid medication adjustments, it only took on average 17 days to get these patients to goal. And then they spent 74% of their time under control. We were also able to get 84% of our patients to reach their guideline-driven blood pressure goal. And we learned from this project that a mobile health platform coupled with this team-based care could be used to improve blood pressure control and keep patients engaged in their own health. Patients were satisfied with the service being provided, and I think that they maintained that engagement because they knew that someone was going to be on the other end reviewing their home blood pressure readings that they were providing and making adjustments when necessary. And they also rated the app with a net promoter score of 38. Next slide, please. So our next project was within our cardiac outpatient recovery service. So we did some telehealth transitions of care that we implemented as a part of this core group. Our pharmacy team contacted patients within 48 hours of discharge prior to their follow-up appointment. So patients who were referred to this core team were those who were considered at high risk of being re-hospitalized post-discharge. And so when our pharmacists would call, we helped to assist with medication titrations, lab monitoring, and help to coordinate care when necessary. And so we did this for 3 months, and we ended up contacting a total of 71 patients. We found contacting them, 55% of these patients had at least one medication-related problem upon contacting them. And then we identified a total of 131 medication-related issues, and were able to resolve 124 of those prior to their follow-up visit with their cardiology nurse practitioner. 50% of these issues were related to the fact that the medication list was not accurately updated, and 39% of the time, patients were taking their medications differently than prescribed in the electronic health record. In summary, we learned that by integrating a virtual pharmacist into our core team, we were able to identify and resolve more medication-related issues early on, which we believe may have improved readmission rates related to these types of issues. Next slide, please. Earlier, and I summarized some data on our outreach from last year. So last year, we actually had about 20 pharmacy students come in and help us. We did a 2-day outreach, and within those 2 days, we saw 32 patients. 14 of these patients ended up changing their prescription Part D plan. And for those patients who did switch their plan, we were able to save them on average $1,725 for the upcoming year on their medication costs. Now, keep in mind, there is some data that I wasn't able to include. And so for the other 14 patients that didn't change their plan, for a lot of them, we were able to make therapeutic interchanges to help them save money. So for example, maybe we found that their health plan covered Eliquis at a lower cost than Xarelto. And so we went ahead and made those therapeutic changes for some of the other patients. Next slide. So the FDA recall project is our most recent project. It was a collaborative project that was developed with a goal to identify an improved process for informing both our healthcare providers as well as our patients about FDA drug recalls. The FDA recently developed what they call a health citizen recall widget that provides timely notifications to both healthcare providers and patients with up-to-date drug recall information. And so this year, our primary care team, as well as our cardiology clinics, teamed up with the FDA and tested their drug recall widget within our electronic health system. UCSF, and especially our cardiology clinics, were greatly impacted over the past few years, especially with these recent ARB recalls that have been ongoing for, it feels like, years. So we were really excited and optimistic about the opportunity to improve this process. And so if you can take a look at the left-hand side of the poster here under design, you'll see a breakdown of the process. So essentially what would happen is that each night, UCSF's IT team would scan the FDA data to detect if a consumer level recall had happened. And then the system would compare the recall information to the patient's medication list in the electronic health record. And if the patient was found to be taking one of the medications listed on the FDA drug recall list, then the patient would receive a MyChart message with a link to a customized widget, providing them with further information about the drug recall that may have affected them. And so in order to test the widget, we used an example patient case, prescription label, and MyChart message that we created. And you can see pictures of that in the center of the poster here. And we tested the widget using a Zoom interview. And so as of today, we've interviewed a total of 9 patients. 2 of those 9 patients had one of their medications recalled in the past, so they had some experience with it. All of the patients seemed to understand the purpose of the MyChart message after they read it. And all of the patients were able to identify the manufacturer listed on the prescription label. But only two of them would have clicked on the link to the widget without guidance, which means that most of them likely would not have obtained the appropriate information to move forward. All of the patients would have contacted their pharmacist, which in this circumstance would have been the appropriate thing to do, considering the fact that the manufacturer on the widget matched that on the prescription label that we provided. But unfortunately, still 5 of the patients would have still contacted their doctor's office, despite being told to contact their pharmacy as they have the most up-to-date information. And then all of the patients, after having completed this, still felt that they wanted to receive a MyChart notification of potential recalls from UCSF because they felt that UCSF was a trusted source. And they also felt that MyChart was an efficient and reliable way to get a hold of them. If you don't already know this, typically when a medication is recalled, the pharmacy is the one who reaches out to the patient, but there's no protocol on how to do this. So different pharmacies do it in different ways. Some pharmacies contact the patients, other pharmacies send letters to patients' homes. And so our patients felt that MyChart was really just the best way to inform them and the most reliable as well. They did give us feedback that the MyChart message was too wordy and detailed, and that the widget contained irrelevant information that may cause confusion for some patients. And patients felt that since the message came from their doctor, that they wanted their physician to be involved in closing the loop. And so even though they were informed in the MyChart message that only the pharmacist knows if they were truly affected by the recall, they felt that they wanted their doctor to be involved. And so we learned a lot from this project, and we hope to make improvements on the widget as well as on the MyChart message, and plan to consider implementing this as a part of our services moving forward. And so that's something we're still working on. Next slide. So now we'll talk a little bit about what happened once we had to deal with COVID-19. So Nisha Parikh, who you'll hear from in a little bit, was a wonderful leader in taking on our cardiology research group. And she put together a group to work on protocols and collaborate on research projects. And so I've been able to participate in that. And my primary role in this group was to help provide up-to-date information to our patients. So I'm sure you all probably experienced the same thing, but when this first happened and we were all told to stay home, our patients started calling and we got really inundated with a lot of questions. And I think a lot of our patients felt anxious and nervous about what they should do and whether or not they should continue certain medicines after hearing a lot of things on the news. And so what myself and my pharmacy did is we created smart phrases to help the common questions. For example, the NSAID question and whether or not it's safe to take ibuprofen, whether or not they should continue their ACE inhibitors and ARBs. And then we were getting a lot of questions regarding what over-the-counter medications were safe if they were to develop symptoms of cough or cold. considering their cardiac issues. And so we put together smart phrases to help answer those questions in a more efficient manner. And then we also received a ton of phone calls related to concerns about potential side effects to medications. So for example, a lot of our patients who are PCSK9s were calling because they saw that PCSK9s may cause flu-like symptoms. And so they were worried that they weren't going to be able to differentiate whether those flu-like symptoms were coming from their medication or from them having COVID. Others were calling with concerns about continuing their statins because they know that statins can cause muscle aches. And they understand that if you get COVID, you may have some muscle aches as well. And so we got a lot of questions. And so my primary role has been to help provide our patients with information, calm them down, and also just discuss risk benefits of continuing their medications in collaboration with our cardiologists. Next slide. So now we'll talk about that transition for us to telehealth for the rest of our team. As I had mentioned, a lot of my work was already being done remotely. So we had to identify a way to get the rest of the team onto telehealth. And I just wanted to include this because I think it's outstanding what we were able to do in such a short time period. As you can see, these are two of our busiest clinics, Mission Bay and Daniel Burnham Court. Our Mission Bay clinic was able to get 90% of our staff working completely remotely within 1 week. And our Daniel Burnham Court was at 65% at the end of 1 week. And so next slide. I just want to, I really believe and I attribute our success to our team who, despite being distanced, really came together and worked together more than I've ever seen us work together before. And our leadership did an outstanding job in strategizing what we could do to best utilize technology and keep things running in a similar manner that they had been before. Our administrative staff put in IT tickets and quickly got us access to the technology and resources that we needed to be successful. And then I also wanted to give a shout out to Doximity, who rebuilt their app within 2 days to allow access to all healthcare professionals. So our entire front desk staff and other healthcare workers who didn't previously have access to the free Doximity app were now able to join a healthcare team of any of the cardiologists in our clinic, and they were able to utilize that to contact patients from home. And so I'll talk a little bit more now about the various means of technology that we've used to help us become successful in working remote. Next slide. So I had mentioned my structure prior to COVID, and now I'm going to talk a little bit about what has changed. So I'm still receiving my typical referrals for all of the services that I provide, but instead of doing that initial consult in person, I'm doing that over Zoom and Doximity video visits. And I use various platforms depending on what the patient has access to, and I'll talk about that a little bit later. And then I follow that up with typically telephone calls on Doximity. So something that I've had to do is become a little bit more creative in terms of my typical in-person visits. And so instead of verifying home blood pressure monitors with a manual blood pressure reading, what I've had to do is just get on the screen with them. I have a blood pressure monitor here at my home. And so I will show them what a good blood pressure reading would look like, how they should be sitting. And then what's nice is that I can now see, while they're in their home, how they would typically check a home blood pressure and kind of walk them through and coach them on how to adequately check their blood pressures. We've also gotten a little bit creative if we feel that we're getting some odd blood pressure readings or odd numbers from their machine. Sometimes I've had them check their family members' blood pressure to see if they also seem odd. And if so, we've been sending patients either into a local community pharmacy, how far they live from the clinic, or we'll bring them into our clinic as we are still seeing urgent issues, and we'll have our nurses do a quick home blood pressure check if we feel that that's necessary. And next slide, please. So these are some of the telehealth platforms that we've used. As I mentioned, Zoom has been really awesome for video visits for that initial in-person visit. And I like the fact that I'm able to get my learners on board on Zoom with me at the same time, so they're able to participate in the encounter just as they would if we were all in person. But what becomes difficult for some patients is that not all patients have access to MyChart. And so our front desk staff typically schedule Zoom meetings by sending the link to my specific Zoom or the other provider's specific Zoom to the patient via MyChart. And so for those patients who don't have MyChart or don't have access to email, I like to use Doximity video instead, because the Doximity video sends a text message to the patient instead of an email. And so they're able to go directly from the text message link into the video call. And I'm also able to add on my students, residents, learners, family members, or caregivers to the Doximity videos as well. And so that's been a really helpful resource to me. And then when I contact patients via Doximity over the phone, what's nice is that Doximity kind of masks the call and it makes it look as if we're calling from the clinic line, which is nice for a lot of our patients who don't answer the phone when they see a number that they don't recognize. And then I've been able to three-way in my students and residents so that they still are able to get the same learning that they would in the clinic. Next slide. I just wanted to show
10 minutes.
Okay, thank you. I just wanted to show some of you what Doximity looks like in case you haven't used it. So on the left-hand side is the mobile health app. And I've circled some of the areas that you would select to use either the video or phone call. And then I also wanted to mention that I do use Doximity for fax as well. Our clinic typically receives a lot of faxes from pharmacies asking questions like, did you know that there's a drug interaction between this, and do you still want them to continue? And so I help to answer a lot of those faxes. And what I'll do is I'll just complete the documentation on my computer, and I'll typically use the mobile, not the telephone app, but rather the internet form of Doximity to send over those fax responses. And so that's also been really helpful. And then in addition to that, you can message colleagues with HIPAA compliant information and ask questions, etc. Next slide. These are the two platforms that we use for our prior authorizations. CenterX is implemented into Epic, which is nice, but can't be used for our Medicare patients. So for our Medicare patients, we primarily use Cover My Meds, and all this work is done by our pharmacy technician, who's been able to do all of her work completely remote using these platforms. Next slide. We've also found that our eFax has been an outstanding tool that we're thankful that we implemented prior to COVID. So essentially all of our faxes that come into the clinic now come in electronically, as well as our voicemails that patients leave when they call and leave a message. All of those are forwarded to an email pool, and our staff members are assigned to that email pool to help push messages to the appropriate parties. And then all of these messages, when pushed to the appropriate parties, are received via secure email. I wanted to tell you a little bit more about some other telephone tools that we use. So our medical assistants prior to COVID were meeting with their doctors on a daily basis just to kind of check in and see how the day was going to be run. And so they've continued to do that over the cell phone, talking with their providers at the beginning of each day. And then we've also been able to utilize our Cisco phones to create what they call ADE extensions. And so a lot of our front desk staff are able to log into those extensions online from home and answer all of the incoming calls that are coming in through clinic. Next slide, please. And the really nice thing about these Cisco phones is that we're able to generate a report daily. And so our admin are able to check in on our staff to see how well they're doing. So this shows how many incoming calls there were, how many of those incoming calls were answered, how many were transferred to another line, and how many of them went to voicemail. So we can keep track of how well we're doing at answering our phones. Next slide. Another tool that we've found really useful is Jabber. We use that as a way to communicate with all of the staff within the clinic. So when I'm finished with a patient and I want a follow-up scheduled, I just message our staff through Jabber and they go ahead and get that taken care of. We also use Jabber to talk back and forth. If an urgent call comes into the clinic that I need to address, they'll message me through Jabber to inform me of this. And then InBasket is used for me to communicate with the cardiologist and update them on how the patients are doing. And then again, we use Zoom for faculty meetings, grand rounds. We have daily huddles that I really think are working well. So at 9:30 every morning, our entire staff gets on a Zoom meeting and kind of gives updates as to how well things are going and what needs to be improved. And then I like to use Zoom because I can share my screen in order to orient my students to our clinic site. Next slide. So what are the lessons that we've learned since switching to completely remote work? I believe that both our patients and our providers appear to be really satisfied with the work that we're doing. Our chief of cardiology has mentioned that we plan to continue at least 30% of our visits, if not more, through remote telehealth if possible, just because of the great feedback that we've been receiving. I have also found that I've received more accurate patient health data. When I am on the phone, when I have someone come into the clinic with me, a lot of times they're rushing to get there. They sit in 30 minutes of traffic over the bridge. By the time they get to us, they can't find parking. And then once they do find parking, they're having to run into the clinic to try to get there on time. And then we expect to check their blood pressures and have their blood pressures in a normal range. I don't think so. And so what I've really learned is that I think we're getting a little bit more accurate data when we're having them do this in their own home where they're sitting and relaxed and where they normally would be checking. And then I'm also able to see if they're sitting appropriately and where they're sitting. And so I think that that's helped me in many ways. Another thing that I've identified is that when I ask people to go grab their medication bottles, a lot of times I identify certain things like maybe they're keeping their medication bottles in the bathroom where they shouldn't be keeping it, and various other medication related issues in terms of how they're taking their medications. So it's been a very useful thing for me. And I've also found that I've become more efficient in my work because rather than having the front desk staff come interrupt me and tell me that there's an urgent call on the line, they just send me a Jabber message and I am able to take care of that on my own time. Next slide, please. One last thing that I didn't mention under lessons learned that I think is really important and valuable is that lifestyle modifications work. I've been having to change around the way that I'm treating high blood pressure because of the issue of having patients go in to get regular blood draws. And so rather than giving our typical ACEs and ARBs and other medications that most of our cardiology patients are already on, we're leaning more towards using calcium channel blockers, hydralazine, and things like that to get their blood pressure optimized so that we don't have to send them to the lab if possible. But in addition to that, I've had some really, really wonderful experiences doing deep breathing with my patients. A lot of them are just really nervous and anxious, and that's driving their blood pressure significantly. And I'm actually amazed by what I've seen after doing 1 minute of deep breathing and having them recheck their blood pressures. I've also been working really closely in collaboration with our excellent dietitian. And I think that by working together, we've been really successful in helping people push lifestyle modifications now that they're at home and have time to be doing some of these other things. So what are our plan and goals moving forward? The clinic is planning to reopen at a limited capacity, and we've really restructured the entire clinic to maintain social distancing. And as I had mentioned, we plan to keep a lot of our telehealth going on moving forward. We've reassessed our pharmacy team workflow, and we plan to include mostly remote work moving forward in the future. We're working on further developing our hypertension program and exploring different platforms that will allow patient data to come into Epic as discrete data. We're working on a pharmacy technician refill protocol, as well as on a group medication classes for our cardiac rehab group. And we're hoping to continue to explore more opportunities for pharmacist billing, as we feel that that's the limiting factor holding us back from expanding. And my goal really would be to have a clinical pharmacist as well as technician in each one of our clinics as we move forward. And that's all I have. So thank you for your time.
Thank you very much. We really appreciate that. It's an impressive system that you have, and I'm impressed that you were able to get it up and working it that effectively. We're still a little bit over time, so if possible, if you could wait for, and we'll do the Q&A at the end, we'd appreciate it. And for those individuals who are online, you can submit directly on the top to the Q&A, and we will answer those questions. If we don't answer them today, we'll answer them, on this line, we'll answer them later today. So let's go forward, I think, at this point. Today is the day after Mother's Day. I think most of us, if not all of us, have a mother. So this is an important follow-up on women's health. And if we talk about the COVID, we realized already today that the ACE2 inhibitor, which COVID uses to get into our cells, is expressed only on the X chromosome. So women have 2 copies of that versus 1. And we did realize or show earlier that women have a better immune system with CD8 counts than men as we get older. And that might explain why women do a little bit better with COVID-19 than men. To further discuss this, I'm going to have Susan Ivey actually introduce our next speaker. Susan is a co-chair of our Right Care program in Sacramento in the capital area. And we're delighted to have her on board today to introduce our next speaker, where we're going to focus on an update about women's health. Susan.
Thank you, Bill. And thanks, Rose. That was interesting catching up on a lot of the technology changes, including the deep breathing exercises. I know our coaches are being trained to do that too. Before I started teaching at UC Berkeley, I was part of a unique program with the American Medical Women's Association that pulled together a group of women in medicine to begin a Train the Trainer program on women and heart disease. This was back in 1997, and people didn't really think of women and heart disease necessarily in the same phrasing at that time. We thought about breast cancer, women's reproductive health, osteoporosis, but heart disease, Framingham hadn't really given us the impression that heart disease belonged to women. Roll forward from that early understanding we had, which was that most women will die from heart disease, to the latest generation of women in medicine who are busy looking at the connections between our heart and our reproductive health and the lifespan of how women get heart disease. For that, I'm happy to introduce our speaker, Dr. Nareesh Parikh. Dr. Parikh was an associate professor of medicine and cardiovascular medicine at the UCSF School of Medicine. She's a non-invasive cardiologist who sees both men and women in her clinical practice and who emphasizes primary and secondary prevention of cardiovascular disease. She also has a key interest in women's cardiovascular diseases across the lifespan, including cardiovascular disease in pregnancy and the postpartum period. Dr. Parikh also has an MPH and is trained as a cardiovascular epidemiologist and population scientist. She has added significantly to our scientific knowledge about specific reproductive factors that are predictors of heart disease using a variety of data sources, including the Women's Health Initiative study and data from the Swedish population registers. Her work has been supported by the American Heart Association, the National Heart, Lung, and Blood Institute at NIH, and the UCSF Preterm Birth Initiative. And she also serves on the American Heart Association Board of Directors for the Bay Area. The title of her talk today is Pregnancy, a Stress That Predicts Future Cardiometabolic Outcomes in Mother and Child. And thank you, Dr. Prick, for bringing yourself back for this Mother's Day Monday. Thank you.
It's a pleasure to be here. Thank you so much for that welcome and introduction. I wonder if it's possible for me to control my slides or whether I should say go forward. The only reason I ask is I have a few custom animation features in there that might be easier to control on my end.
For the sake of simplicity, Dr. Parikh, we will keep to having ourselves control your slides. If you want us to advance the animation, you just let us know.
Okay, I'll just say slide forward then.
Thank you.
And it might not actually be slide forward. So I thought in honor of Mother's Day, I would talk a little bit about pregnancy as a stress that predicts future cardiometabolic outcomes in both the mother and the child. Next slide, please. So this concept of pregnancy as a cardiometabolic stress test is gaining a decent amount of traction now, but I thought I would review it for those in the audience who haven't thought much about it yet. If you think of vascular risk as that horizontal dotted black line on the slide, the population of women who are healthy and oftentimes don't have pre-pregnancy cardiometabolic risk would be represented in the blue dotted line. And as they go on from early childhood to adolescence and into their reproductive years, they might experience during pregnancy a blip in those cardiometabolic risk factors, including insulin resistance, maybe increased adiposity, and the things that normally happen during pregnancy. But this won't cross the vascular risk threshold. And then the same might be true with their second pregnancy. And as they age, of course, their risk might get a bit higher. But if you contrast that with the population of women who will develop a pregnancy complication such as preeclampsia or high blood pressure during pregnancy, gestational diabetes, then those women probably started at elevated risk before they have pregnancy. And then during the pregnancy, they actually sort of frankly cross that vascular risk threshold. So they will develop diabetes during pregnancy or hypertension or what have you. And that's probably accentuated in their next pregnancy to a certain extent. And then we know now that those women go on to develop cardiovascular disease at an earlier age. Next slide, please. So the key questions I want to address with this talk are: why is this topic important? How is normal pregnancy related to cardiovascular disease? How are adverse pregnancy outcomes, which is another sort of name for pregnancy complications, if you will, related to CVD? And then can we use a history of that to understand CVD risk in both mother and children? What's the evidence around that? And then I'll touch briefly upon how other reproductive factors in the mother could be considered, and how can this change our clinical practice or the way that we think about healthcare delivery. Next slide, please. So I think one of the reasons that this topic is very important is that cardiovascular disease accounts for the number 1 and number 3 or 4, depending on the year, cause of death in US women. And this is data from 2015. Next slide, please. The other sobering statistic is that we now are seeing that there's a stagnating sort of decrease in coronary heart disease or CHD mortality among young women. In older men and women, age 65 and older, you can see that among men, sort of that top lighter gray or lighter black, I should say, graph shows that men older than 65 are experiencing a decline in their coronary heart disease death, and women are as well, but it might be a little less steep. Next slide. This is a little bit more of a divergence among middle-aged men and women, as seen here, and then next. And in younger ages, age 25 to 54, you can see that there's really a relative like flat sort of slope in women as compared to men. Next slide. And this led Betsy Nabel, the former director of the NHLBI and now president of Brigham and Women's Hospital, to sound the alarm that our heart disease prevention efforts might not be reaching younger women. Next slide. So US mothers have increasingly adverse health as well. Next slide. And you can see in this Lancet article that looks at the global rates of maternal mortality, as compared to other developed countries, the US maternal mortality rates have been increasing significantly. And this is in sharp contrast to most of our other like GDP countries in the developed world. Next slide. And why would this be relevant to cardiovascular disease? Well, if you look at the causes of pregnancy-related death in the United States over recent years, cardiac or pulmonary vascular causes really account for quite a few of the pregnancy-related death causes, and those are represented in the red histogram bars. And you can see that cardiovascular disease is indeed the leading cause, and that cardiomyopathy, pulmonary embolism, stroke, and hypertensive disorders of pregnancy are underlying many of the other major causes as well. Next slide. There is a disparity in maternal mortality by race ethnicity, which cannot be ignored, such that African American women experience much higher rates of maternal mortality. And many of these are not explained by risk factors. Next slide. And this has been picked up by the lay press as well. Next slide. And then at the same time, there is this issue of worsening cardiometabolic health among children. These are childhood obesity rates in 2003, with the darker blue representing worse obesity rates. Next slide. And if you contrast that with 2017, you can see that the whole map gets darker, if you will, and obesity rates are rising. Next slide. When we think of cardiovascular disease prevention in an individual, I think there's been an increasing emphasis on a life course approach, which is a good thing. Assessing risk at earlier years during childhood and teenage years, for instance, or early adulthood. Next slide. But I would argue that we're still, for the most part, modifying risk factors in adulthood. Next slide. And certainly, I don't think we've been really taking the bent that mother and father's cardiometabolic health affects baby's health in utero and beyond. Next slide. So I think these are missed opportunities. And in terms of women, there are two missed opportunities in particular. One is during these childbearing years, sort of understanding that these CVD risk factors actually affect the next generation, and really considering that there are in utero effects of pregnancy and pregnancy complications. And this is important, I think, because 85% of women experience a pregnancy. 15%, on the other hand, experience nulliparity or are not being pregnant in their lifetime. 15 to 20% of women, and in some estimates, up to a quarter of women have one or more adverse pregnancy outcomes if they do get pregnant. Of course, 100% of women have a reproductive history, and 100% of kids have a birth history, just like we all have mothers, right? As Dr. Ballmer mentioned. Next slide. And my research really over the past decade plus has focused on various sort of overlapping exposure categories, if you will, of pregnancy, maternal adverse pregnancy outcomes, or APOs, fetal outcomes, including their birth weight, history of preterm delivery and pregnancy loss, and then the reproductive factors listed on the slide. These are often correlated, interrelated, hard to separate entirely. But I really think of them in these separate categories just to sort of make it a bit simpler. Next slide. So first, I'd like to tell you a little bit about some work on pregnancy and CVD. Next slide. So pregnancy, as I mentioned, has many physiologic changes accompanying it during the normal pregnancy, and they're listed on this slide. Next slide. And so we asked the question, with all these sort of changes in cardiovascular biologic systems, is pregnancy itself, or pregnancy per se, a risk factor for cardiovascular disease? Next slide. We also wondered if the physiologic changes that happen during a normal pregnancy that affect the maternal heart in terms of vascular function And hemodynamics, increase preload, decrease afterload, and an effective shunt to the uterus and placenta and the growing fetus, as well as changes in the renin, angiotensin aldosterone system. Do these changes accumulate over successive pregnancies? Because during a pregnancy, it's true that if you look at the graphic over the duration of a pregnancy, left ventricular mass will increase in a normal pregnancy by 30%. Volumes of the heart will increase in a woman to accommodate all these changes that we listed. And then the ejection fraction or squeeze function of the heart goes up and then down, sort of back to normal throughout the duration of pregnancy. Next slide. And when you think about conditions that lead to remodeling of the heart, next slide. If this center heart is sort of normal, the top heart's normal, and you think about exercise and pregnancy, traditionally they've been put into this bucket of being normal physiologic hypertrophy, so good things. And if you contrast that with pathologic hypertrophy over to the right, that's caused by hypertension, a heart attack, what have you, then these are really traditionally been thought of as separate entities, with pregnancy being quote unquote normal and maybe accommodating all those systems of the growing fetus during pregnancy, but then eventually going back to normal. Next slide. But given all the sort of biology, we wondered if this was true, and we studied this in a few different ways. Next slide. Our first series of studies just asked the question of whether pregnancy was related to cardiovascular disease, and this was data from the Swedish registries showing that there was this J-shaped association between number of pregnancies and cardiovascular disease among women in that country, with the nadir of risk at 2 pregnancies. Next slide. We next showed that number of pregnancies, or number of live births in this case, in the multi-ethnic study of atherosclerosis was associated with increased left ventricular and systolic volume on the right upper hand corner, diastolic volume in the, left and right upper hand corner volumes, and decrease of ejection fraction, and an increase in LV mass. Next slide. We also, in the Women's Health Initiative, showed that having 5 or more pregnancies was associated with increases in the PR interval, which can sometimes tell you a little bit about atrial conduction. And also with there were associations with the QTC interval as well. So electrical remodeling in the heart. Next slide. And more recently, one of our fellows who's now on faculty at UNC in Raleigh, Philip Hall showed that nulliparity was associated with heart failure with preserved ejection fraction, or diastolic heart failure in the Women's Health Initiative, with a 2.7-fold increased hazards of that outcome. Next slide. And then in terms of that, the electrical remodeling, and a separate group in Boston has shown that increasing number of pregnancies is related to atrial fibrillation, which sometimes can be seen after first seeing changes on the electrocardiogram, including increase in PR interval. Next slide, please. So pregnancy per se is related, at least in observational studies, to cardiovascular disease, myocardial remodeling, electrical remodeling, and atrial fibrillation. Next slide, please. Now we'll turn to maternal adverse pregnancy outcomes, including hypertension in pregnancy and gestational diabetes. Next slide. So we think of hypertension in pregnancy as a maternal and fetal vascular disease with some paternal contributions. This is sort of a schematic of what happens during preeclampsia. So on the left-hand upper panel is actually, this is a spiral artery, and this depicts normal implantation into the myometrium of the uterus, which is sort of that lighter lavender. And with that, you get sort of this normal growth pattern of the placenta. However, in preeclampsia, this is a shallow implantation that's incomplete. And so this is believed to be one of the reasons that you have sort of the downstream effects of preeclampsia in the mother. And if you look at the placenta, you can actually sometimes see infarction, much like we do in the heart. Next slide. As well as hypertrophy of the arteries in the decidua, or the part of the placenta that's closest to the maternal fetal interface. Next slide. Maternal factors that can lead to hypertension in pregnancy are hypertension itself, chronic hypertension that is, or an elevated blood pressure pre-pregnancy, excess body mass index, stress, their diet, exercise, family history, and genetic components as well. Next slide. And sometimes that hypertension in pregnancy is accompanied by growth restriction of the fetus. And that itself is a vascular phenomenon. If you look at the umbilical artery Doppler of a baby who has fetal growth restriction, this artery Doppler can be abnormal, showing an abnormal flow pattern to the placenta. Next slide. Next slide. But fathers aren't off the hook here, because it's true that having preeclampsia in the father's mother, paternal obesity, certain HLA-G variants, and having a change in paternity from one father to another are all risk factors for preeclampsia. Or actually, the change in paternity is, if you have preeclampsia in one pregnancy, changing the father can be a risk factor for not having it in the second. Okay, next slide. And this is some data from a meta-analysis that shows that a history of preeclampsia in the mom can be related to a twofold relative risk of having cardiovascular disease mortality in this meta-analysis later in life. Next slide. Next slide. And this is also showing that preeclampsia in the mother leads to offspring hypertension. This is a meta-analysis of 18 studies showing an increase in systolic blood pressure of 2 millimeters of mercury and 1.4 diastolic blood pressure increase. Next slide. Next slide. Preeclampsia has also been associated with congenital heart disease in the fetus. Next slide. Atrial septal defects. Next slide. Hypoplastic right heart syndrome. Next slide. And other complex congenital heart disease. Next slide. With an adjusted risk ratio of 2 for congenital heart disease if a mother has preeclampsia. Next slide. Gestational diabetes is another adverse pregnancy outcome that's important from the standpoint of being common and also costly. Next slide. It's true that gestational diabetes is associated with cardiovascular disease. Next slide. And there's also effects on the fetus. If you look at this BMI growth trajectory, among women who are exposed to preeclampsia, the BMI growth trajectory of their children is much higher, or significantly higher than those not exposed, not having gestational diabetes. And this is thought to be due to an increased glucose transfer to the fetus, fetal hypoglycemia, which stimulates islet cell proliferation and insulin production. And then there's also some evidence that there's a role of epigenetic modification of the fetal genome. Next slide. We are studying this in the context of a Kaiser cohort of women called the SWIFT study. The PI is Erica Gunderson at Kaiser. And this study follows about 1,000 women from baseline to a 10-year visit that's been funded and hopefully will start soon. Our study, next slide, would ask the questions: which women with gestational diabetes will go on to develop a higher cardiovascular disease risk? And then to what extent can lifestyle changes alter the risk trajectory? Next slide. We are also studying adverse pregnancy outcomes in an older population in the Women's Health Initiative study, which now contains about 70,000 women that are still being followed in the study. And they're about kind of on the average in their 70s now. We submitted this form as a survey and mailed it out to women in the Women's Health Initiative, and it asks about a series of adverse pregnancy outcomes. Next slide. And these are our results, which are actually in submission to a journal now, as well as had been accepted by this Q-Core meeting at the AHA. We found that most adverse pregnancy outcomes, even when adjusted for traditional risk factors, with the exception of having a high birth weight baby, were associated with cardiovascular disease in postmenopausal women. So that was actually somewhat surprising. We didn't know whether the association might wear off, if you will, in the older years, but it turns out that there's still a significant association, even though the actual hazard ratios might be somewhat attenuated, with gestational diabetes, for instance, having like a 1.2, 5 or so increased hazard, with hypertensive disorders having about a 1.3 increased hazards of CVD. Next slide. We recently published this data in Journal of Women's Health, and this was really asking the question of why is that? Is it just that the women have pre-existing elevated levels of risk factors, or is it that there's some difference that's experienced by having the adverse pregnancy outcome itself? So in this study of the MAMAS cohort, of which the PI is Alyssa Epple at UCSF, we looked at whether in the red, women who have adverse pregnancy outcomes during their pregnancy compared to the women in blue with the normal pregnancies, we asked the question using mixed model regression, are the levels of risk factors different or the trajectories? And it turns out for glucose and systolic blood pressure, the trajectories are actually different. So that these women start off with probably somewhat elevated levels of glucose and blood pressure, but really it's the trajectory that's different for women with adverse CVD-related pregnancy outcomes. So there might be something about the pregnancy per se that is leading to altered risk factors post-pregnancy. Next slide. And now we'll turn to fetal outcomes. Next slide. We and other groups have also shown that having preterm delivery or a small for gestational baby, so a baby that whose size is small for whenever they're born, is associated with CVD, and that there might be synergistic effects of those two exposures. Next slide. So if you're a mother who has a very preterm infant born very small, then you might be at almost a 3-fold excess risk for cardiovascular disease. Next slide. Compared to if you had a term delivery and a baby not born small. Next slide. And this is also relevant for the offspring. So the way that this whole field developed was with Barker. I don't know if any of you are familiar with Barker, but he had Barker's hypothesis based on looking at people born during the Dutch famine and noticing that they had elevated cardiovascular disease risk in adulthood. This was recapitulated in the Biafran famine in Nigeria. And if you notice that among men and women in the gray and blue bars respectively, those who were born in the famine, those who were in early childhood, I should say, during the famine, had lower odds of having high blood pressure. Next slide. However, those born during the famine had higher blood pressures, and those born after the famine had lower blood pressures. So the same thing was recapitulated in the Biafran famine. And then on the right-hand panel of Swedish men in the conscript registry in Sweden, the authors show that one has higher blood pressure if they are born preterm, as you can see with the gestational age graph on the left-hand side there. Okay, next slide. Pregnancy loss is another fetal outcome that has been associated with cardiovascular disease, and this is looking at data from several studies showing that there is an association between pregnancy loss and CVD, albeit modest on the whole. Next slide. We wondered whether pregnancy loss was associated with having more CVD risk factors in the postmenopausal years, and found that that was the case indeed. This is very busy, but women who experienced pregnancy loss in the Women's Health Initiative had higher body mass index and were more likely to have hypertension and slightly elevated systolic blood pressure, as well as diabetes and dyslipidemia. Next slide. There are also a number of reproductive factors that are associated with cardiovascular disease, which play into the story. Next slide. Next slide. We wondered about nulliparous women and women sort of on the left-hand side of the J-shaped just the curve of number of pregnancies and CVD. Next slide. And we hypothesized that maybe this is related to impaired fertility in some way, polycystic ovarian syndrome, thyroid disease, perhaps depression, that might mediate some of those associations. Next slide. And so there was some prior data suggesting that menstrual irregularity, which is associated with infertility, is related to coronary heart disease, as well as cardiovascular disease death. And menstrual irregularity is also a proxy for polycystic ovarian syndrome. Next slide. We looked at this also in the Swedish population registers, and this was years of subfertility or experiencing fertility before going on to get pregnant, and cardiovascular disease event rates. Next slide. We found that if a woman reported 5 or more years of subfertility, then she had a hazard of 1.24 of CVD, but we don't know exactly what drove this. Next slide. There are some things that one can do in terms of reproductive factors in early postpartum, which is breastfeeding. And this has benefits on moms, but it also has in terms of weight loss and cardiometabolic health of the mother, and also on the offspring. So in this investigation in the Framingham Heart Study, next slide, we showed that if you had been breastfed for 1 month in infancy or more, this was associated in the Framingham offspring with higher adult HDL levels and lower mean body mass index. So the study suggested that the benefits extended beyond childhood to adult health outcomes. The benefits of having been breastfed, that is. Next slide. In the latest iteration of the prevention guidelines of the American Heart Association is age at menopause and time since menopause as being potential risk modifiers or risk enhancers, excuse me, that might lead one to consider a statin. And it would be an early age at menopause that's associated with coronary heart disease risk, as well as stroke risk. And these are meta-analyses of those associations. Next slide. So this is sort of, to sum things up, that perinatal, maternal and fetal neonatal outcomes are cardiometabolic stress tests, not just in the mother, but in the baby as well. Next slide. So if you think about the mother, we'll just summarize what we learned about that. Next slide. Subfertility, breastfeeding, and I didn't mention postpartum depression, but we have some data on that as well. Menstrual irregularity and age at first birth are reproductive factors in the mom that lead to either excess or less CVD risk. Next slide. Preeclampsia, preterm delivery, having a small or low birth weight low birth weight baby, gestational diabetes, and pregnancy loss or pregnancy complications that lead to cardiovascular disease in mothers. Next slide. And early age at menopause. Next. And thinking about the baby side, what the excess risks are. Next. Having breastfed is a good thing for baby in terms of later cardiometabolic benefits. The age at first birth, which I also didn't go over, and IVF might be relevant for baby. Next slide. And also having been born to a pregnancy with these pregnancy complications listed, preeclampsia, GDM, preterm, and having low birth weight obviously would be can be harmful in terms of later cardiovascular disease for baby as well. Next slide. So how can we use this knowledge to prevent CVD in women with these reproductive factors or pregnancy complications? So which risk factors are important and which ones can we target? Next slide. This is a meta-analysis from a in progress AHA pregnancy CVD statement that we are working on. And the truth is that many studies, not just the ones I mentioned and tried to summarize in meta-analyses, have shown that preeclampsia is related to hypertension, diabetes, and dyslipidemia. And that is certainly an area that we can concentrate on. Next slide. There are, on the other hand, pretty few studies of lifestyle modification for women in the postpartum period. And in particular, women with adverse pregnancy outcomes haven't been really studied much at all. So there is a little bit of data that there might be some beneficial results, but then some studies show mixed results. But as you can see by the ends in these studies, ranging from 21 people to 206 women, there really isn't, these aren't robust, like large sample size studies. Next slide. Again, our cardiovascular guidelines show that history of premature menopause may be important and pregnancy complications. Next slide. And then we're almost done, but I just wanted to mention that the timing of the postpartum visit for women with CVD-related adverse pregnancy outcomes, currently we schedule these postpartum visits at 6 weeks, but 40% of mothers don't attend. 28% of women do from 18 to 44 see their OBGYNs annually. However, only 19% go to a general or family practitioner. So one question that's been posited is, should we have a CVD risk factor visit around 6 months or 1 year postpartum for women with these adverse pregnancy outcomes for enhanced continuity? Next slide. And then in terms of thinking about treatments, we now do recommend a low-dose aspirin for women at high or moderate risk for preeclampsia from week 12 to 36 to 37 weeks. And that's a 1A recommendation now. And we do this at UCSF. There is a statin trial that had been potentially underway at NIH, but I don't believe it's gone forward yet. And that would be statins during pregnancy, which of course would be, I'm sure, somewhat of a controversial issue, given some of the at least understood effects of statin during pregnancy. Next slide. And then in terms of fetal outcomes in cardiovascular disease, really, this should be something that I think deserves a lot more continuity than we probably are giving it. And so the in utero exposures and mechanisms we propose should really be thought of in the mothers. And then you sort of have to, carry the baton forward with the various practitioners up until CVD develops later. So really taking a lifespan approach. Next slide. And then this is just quickly, almost at the end here, future of epidemiologic studies, and you can go through this and continue moving forward through this graphic next and next until this slide is over. But it's basically just showing that I think we need more intergenerational studies to look at this. And then finally, to conclude, And yes, you can move to the next slide. Pregnancy is a cardiovascular stress test. Preconception factors can unmask the predisposition, as well as pregnancy outcomes. This is important in both the mother and child. The in utero environment sets the cardiometabolic health, and we need more studies on this and more intervention. So, and that is my last slide. And these are just my acknowledgements. So I know it's been a long session of really great speakers, and I'm going to just end here. Okay.
Well, thank you very much. That was certainly a very comprehensive review of women's health and the baby as well. We may have time for a couple questions. I know we're sort of, everybody's been patient sitting here for the last 3 hours. You mentioned a couple things while we're waiting for questions. We do know there's a trend, especially in Western countries, to wait longer to become pregnant, to work, to perhaps have limited ability to breastfeed, and perhaps fewer children that we're seeing globally. If you had to pick the optimal for a woman, what would you say the number of children to have or pregnancies would be, the age at which you should have those pregnancies, and the time that you should breastfeed? If you had an optimal selection, what would you go for?
That's a good question. Probably controversial too, for various reasons. But I mean, our data suggests that having 2 pregnancies is perfect, and any less or any more seems to put you at excess risk. In terms of age, we've studied this as well, and it's actually the early age at first pregnancy that is associated with cardiovascular disease in women, and that early meaning before age 20. So adolescent pregnancy is probably not a great idea. We don't know if that's all socioeconomic confounding, but there's this hypothesis that while a woman's still growing, she needs energy to grow for herself. And if she gets pregnant, she might sort of divert that energy to the baby, and then her body feels almost like a scarcity as it's growing. And so it might it's sort of like an endocrine disruptor for her. So that's where the evidence and the sort of like theory lies with the young pregnancy. In terms of like a maximum age cutoff, it's hard to say. I know you tend to have more pregnancy complications as you get older, but the data, it hasn't been borne out in the data showing that like an age at last pregnancy is puts you at higher risk for CVD later. That hasn't been shown, at least in any of the studies that I know of. So, you know, it could just be those who are going to get the pregnancy complication will get it, but I'm not certain. And then breastfeeding, there's benefit even just for 1 month. I think that the benefits on the baby, they say the longer the better, and like a year would be great. 6 months is another time metric, but you know, somewhere falling around that spectrum, I think.
Perfect. Are there other questions related to Nisha that you could answer now?
I thought it was very interesting that you talked about gestational diabetes and the children's BMI, and what you might counsel children, given you know, current trends with increasing gestational diabetes and the impact on children's higher BMI. What can we do about it?
Yeah, I mean, I think that, you know, obviously, I think my pediatric colleagues would be able to better answer sort of exactly what to do about it. But I think that just recognition of the risk is really important in the first step, and just recognizing sort of the early origins of atherosclerosis is probably really important for us as a cardiovascular community. So really kind of taking a more holistic approach than we currently take to cardiovascular risk assessment is important in an earlier approach. So that would be really the pie in the sky, and like kind of the dream is when you have your patient in front of you, even if the patient's a baby, you really sort of say, okay, here's someone I need to pay attention to, because this was, gosh, they're nothing to do with what they're doing currently, but this was sort of the in utero environment, and this is their context. I think that kind of approach is something I'd love to see more of.
Well, that's great. I see that Earl is back on. If we could switch for a second, Earl, I noticed on your very, very comprehensive telemedicine, you are going to have some difficulty with what I would term physical diagnosis. And I, like any physician, spent years learning how to do physical diagnosis. And I wonder what your ability to do that is. You mentioned you had an interaction or a connection for a stethoscope. Have you used that? Because I can tell you as a cardiologist, we spend a lot of time doing physical diagnosis for heart failure, looking at neck vein pulsations, listening to murmurs and valvular disease, et cetera. And that's one of the challenges, I would say, about telemedicine is how to get that same quality of information.
Sure. Let me comment on. So absolutely, the biggest shortcoming of telemedicine is the ability to do actually physical examination. And I did list the electronic stethoscope as one of the devices, but I don't think it's been well received. I think that the quality is not very good from what's reported, and actually we don't use it at our local VA medical center. So yeah, we still need to see our patients for physical examination. But many visits don't require a physical examination. Many follow-up visits, don't require a physical examination. At least nothing that's to a level where we actually need to put our hands on the patient.
Very good. There were one or two questions that I saw earlier on whether we should stop ACE inhibitors or not in patients with COVID. The current recommendation, I think, as I said earlier, is to continue all antihypertensive medicines, including ACE inhibitors and AR blockers. There may be some slight benefit to actually staying on those medicines because they may attenuate or reduce the inflammatory effect on the pulmonary vasculature and the lungs as well. So we would recommend staying on it. I think on other talks on COVID, I'd say the only time I would consider holding those is in the patient who is severe inflammatory response in an ICU, who becomes hypotensive, intubated, and you have to put them on pressors to maintain blood pressure. In that situation, putting them on pressors with an antihypertensive sort of is counteracting each, and I would probably back off of the ACE or the ARB in the situation of cardiogenic shock or systemic shock in that situation. Otherwise, we would recommend staying on them at this time. We don't have real evidence other than in animals on that, but we would not suggest stopping it at this time. It's important for it to continue. Any other questions?
Well, there's a question from Scott Flynn in our chat box to Rose Pavlakos. I believe Rose can see the question, which is, are you going to publish your hypertension control results? They're impressive. Secondly, are you going to do follow-up in a year? Curious as to the persistence of that 74% control rate.
Yeah, thank you, Scott, for the question. So halfway through our study, unfortunately, the mobile health platform lost funding. And so we were not able to continue to use it and finish our study. We do still have some pretty great data that we should publish. And I think that right now I'm really concentrating a lot on where to go next because I'm still providing the same service that I provided when we had the mobile health platform. I just don't have a place to pull my data from. And our real goal is to get our data as discrete data, a discrete data field in Epic so that we can better pull that information on a regular basis to continue to look at the value added by the pharmacist, along with answering questions, as you had mentioned, as to how long these patients are staying within their goal blood pressure, and is that happening long term. So it's in the works, and I hope to have some information to publish very soon.
Quickly, going back to COVID for a second, there was a question, other than remdesivir, are there other antivirals being tested? Yes. And we'll show you, we'll bring back up, or maybe Brian or Megan can bring up the slide that I had on the other antivirals that are being tested while we're talking. So there are literally probably about 50 other drugs being evaluated in protocols. We can't answer whether they're effective or not until we have the data. And perhaps Brian can bring that up on the screen for you. The other question was for testing, are there false negatives? Well, there's several types of testing we talked about. One is actually doing a nasal swab to see if you can obtain the mRNA on a PCR test for it. And is there a false negative? Yes. If you don't sample correctly and obtain all of it, you could say there's no PCR evidence of the virus in your nasopharynx. And so that could be a false negative. We think those rates are maybe 5 or 10%, maybe as high as 20% for the testing. So it does require a relatively extensive and uncomfortable nasal swab to make sure that test is accurate. Other tests are for the antibodies. And you should probably be aware that there's a little over 100 antibody tests that are out there today that are being advertised. Only a few, a limited number, have actually been validated. And how do you validate an antibody test? It means you have to get samples of a lot of individuals who have been exposed to coronavirus, other types of cold from coronavirus, etc., prior to September of 2019. So they may have antibodies to different coronavirus because approximately a third of all colds have been coronavirus. So we've all been exposed to it. We have some antibodies to coronavirus, but the question is, do you have antibodies that are neutralizing or protective against the current COVID-19? To do that, you have to have samples where people have guaranteed never been exposed. Those are samples prior to September 2019. Have those blood samples and test it to your system to make sure none of those become positive at that point in time. And then you have to have verified samples from people who had COVID-19 to show that they have antibodies to COVID-19. The test needs to be 100% accurate to detect the COVID-19 antibodies in those who have had the disease, and 100% negative when individuals who've not been exposed to it. So that validation is not easy to do. It takes time and has not been completely tested for all of those testing options out there. The FDA is turning now to looking at trying some validation for that. There's a few, and it's less than a dozen that have now been validated. So it depends on what test you're using at that point in time. And of course, as in the news, false negatives can occur just because of sampling error in situations where we're looking for the actual virus to culture or the PCR for it. So that is a big problem with testing. And because tests have just come out rapidly, we don't have all of the testing or the validation that we know to prove that they're entirely accurate. So you should be careful when you select your test. Other questions?
Bill, could you please elaborate on the 3 phases of the building of the antibodies and whether or not that confers immunity?
The 3 phases of the building of the antibody. Well, I'm not sure if you mean biologic or in the lab.
Well, you wrote to us a couple weeks ago that you first established IgM, then IgG, then you're continuous.
Oh, I see. Okay, okay. But for 10 seconds here, on the screen here is the slide I used earlier, and it shows at least a dozen therapies that have been used for antiviral and tested for that. Of those 2, remdesivir has had a test or has had protocol that we've been using and does show benefit and is currently accepted as an appropriate drug for treatment. Chloroquine and hydroxychloroquine that are shown just to the right of remdesivir there were initially postulated as potentially helpful, but there are now several trials showing no benefit, and there's one trial showing a slight harm to it, so that's no longer recommended for that. Other tests to the right look at things like azithromycin, a common antibiotic that's often given in patients with COVID because they have concomitant bacterial disease as well, or a co-infection, and that can help to prevent the co-infection with other bacteria for it. The 2 under that are antibodies directed to the actual virus at various stages, and those are being tested at this time. But as I said, there's probably about 50 drugs out there now in the stages of testing to see if they're effective for the agent. Now, your other question was related to antibody or building the vaccine. Which one? So
the key point is that as CDC keeps telling us, that even if you have antibodies, it doesn't mean that it confers immunity, just like with AIDS. Just like with AIDS, not necessarily going to be the case.
So what I answered on the text in the chat box for one of the Q&As was related to antibodies. You've been all exposed to coronavirus. 1/3 of colds in the US are coronavirus. So you all have antibodies to some part of coronavirus. You get a cold, everybody in the family or contacts gets it, and then you develop antibodies and it goes away. So we do have antibodies for it. The question is, do you have antibodies against SARS-CoV-2, the agent or virus that is causing COVID-19? And that requires, in most situations, for you to have neutralizing antibodies to it, meaning that those neutralizing antibodies will, in fact, and what we're looking for in a vaccine is the ability to get resistance and or antibodies delivered at the level of the dendritic cell right after the epithelial cell contacts it. You want to immediately get neutralizing antibodies. Many of those antibodies are going to attempt to neutralize the spike on the COVID-19 virus. Others, the envelope, and others to try to prevent the activation of the spike so that it can enter into the ACE2 receptor. So those would be relatively effective antibodies and prevent it from coming into our body. Other antibodies that are developed may not have an effect until it gets in the cells and starts replicating at that time. So we are not sure what antibodies at this time will be protective from having you acquire the disease again. That is going to require trials. So when we say 6 to 18 months to get a vaccine, well, we already have a vaccine in our lab that we developed from our first patient, and we already have it working in animals. But the question is is it safe? What dose do we need to give? And when we inject it or make it available in humans, and we're trying to patch right now is an innovative way. You put on a Band-Aid patch and that's the vaccine rather than a shot. If you do that, and then you're exposed to COVID-19 at that point, do you come down with any clinical disease or not? And as we all know with influenza, there is protection, but not absolute protection against getting the flu again. If you've had the vaccine and you get it again, it will be an attenuated course. It won't be as so severe. It'll be more limited, less likely to have a severe complication from it. But even influenza, which we've been dealing with for 40 years, we don't have a perfect vaccine for it because it changes all of the time. And we're prepared with the fact that the COVID-19 or the SARS-CoV-2, remember, this is SARS-CoV number 2. There was a number 1 in 2003. This virus can change and it could change again. And if it does, the vaccine may have to be adapted or changed as well. So there is no guarantee that one, we will get a vaccine. We've been working on HIV vaccine for 40 years. We have some. They're not yet that protective. And that's 40 years later for that. So we're hoping and optimistic we'll have a vaccine for COVID-19 in 6 to 18 months. We cannot promise that at this time, and we cannot promise how effective it will be. It requires putting thousands of people on the vaccine and then putting them in an area where they might be exposed to see if it is truly protective and safe. Only then will we know we have an effective and safe vaccine.
So Bill, thank you for your amazing introductory presentation. And I want to thank all of our speakers today. And just for closing remarks, as we have these super scientists with us today that we are so appreciative of fighting at the front lines on this, can you say a few words about what you recommend to your high risk cardiovascular patients? Maybe do a little round robin. How about Dr. So? First, and then Rose, and then Bill to wrap up. Thank you so much.
So I think, avoidance is the key issue at this point, since we don't have a good treatment, don't have a good vaccine. So it's really avoidance and really distancing as much as you can do.
I would say the same. We're getting a lot of calls about staying on medicines or not. And so I've been doing a lot of education in terms of if we don't keep your other issues under control, then you're going to end up in the hospital anyway. And so I've been having to do some teaching and coaching on that side of things. And then we do have some really high risk patients that have called who need to go to the hospital and are too afraid to go. And so we've also been providing education on the other end that when they do need to go to the hospital, it's important that they go. So.
Yeah, I think that Earl and Rose have given all of that information. Obviously, separation is important that we're doing now. And I think for high-risk patients who have well separated themselves, do not become complacent. If you look at Wuhan, China, where they have not had any cases, recurrences in the last month, today they had 7 new cases. So as we open up, we have to be worried about either riplets or waves of this coming back. And we cannot be complacent that we have put this virus to rest. It will probably be with us in many areas on or off for the next year or two. And we cannot rest on our accomplishments at this time. We have to continue with our surveillance, testing, and realize that this is a relatively tough virus and it may change on us to make it even more difficult. We will succeed. There's a light at the end of the tunnel. We just don't know where that end of the tunnel is right now?
I'm hopeful that patients will be coached to do all that they can in the lifestyle arena to lower their need for the medical intervention. So they have more time at home. And as Rose Pavlakos was saying, she's actually finding that some of her patients are improving their blood pressure control, for instance, because they're not dealing with the stressful commute and have more time for self-care. So I want to just encourage us all to encourage our patients to do what they can in terms of eating a plant-centric diet, keeping their exercise going 30 minutes a day, and doing their home blood pressure monitoring. And with that, I just want to say we have 2 more sessions coming up in the next 2 weeks. May 21st and with our normal Los Angeles group, and then on May 26th with our Bay Area group. So as we are now able to virtually connect all of our communities, I think after this month, we will strive to have only 2 virtual sessions a month in the future. So today's presentations were just spectacular, and we still have 40 people with us. So thank you all for hanging in there, and thank you for your devotion to improving patient outcomes, all of you.
And thank you all of our participants and speakers who made this possible, and sponsors. And since you've all been sitting, because I'm watching, for 3 hours, I need you to go out and exercise at this time. Remember, exercise reduces cardiovascular events and it improves your immune system. So you can get 2 for 1 in the next hour if you go out and exercise. Thank you for joining us today.